Hi, I'm Christine Hunter. I'm the Deputy Director for the Office of Behavioral and Social Science Research. I want to welcome you back to day 2 of the NIH Behavioral and Social Science Research Festival. We had a great day yesterday, including a song by Francis Collins dedicated to Bill Riley at the very end. So if you missed it, there'll be a recording up soon and I encourage you to see it. Today's agenda is equally as interesting, starting with our esteemed keynote speaker. So I'm very honored and pleased to introduce Dr. Shannon Zink. Dr. Zink is the director of the National Institute of Nursing Research. She joined NINR in September of 2020, following a 14-year career as a faculty member at the University of Chicago, or the University of Illinois in Chicago, the College of Nursing and Institute for Health Research and Policy. Her background is in nursing and public health. Dr. Zink's own research focuses on community environments as a social determinant of health and health inequities. She and her team conducted pioneering research on food deserts in the United States. And today she'll be presenting on the nexus of nursing science and behavioral and social sciences research. So thank you very much, Dr. Zink, for being here with us. And with that, the virtual floor is yours.
Thank you, Dr. Hunter, and good afternoon, everyone. It's a true pleasure to be with you today and have this chance to join the festival. So let me share my screen. Okay, so again, it's an honor to be here today, and I'm looking forward to sharing with you some information about NINR and our funded research. So here's an overview of my talk today, and we'll have plenty of time at the end for questions and discussion. So I'll begin by providing an overview of what we're currently doing at NINR and our overarching research mission and its connection with social and behavioral research. I'll discuss the makeup of NINR's research portfolio and how it corresponds with the current health and healthcare landscape. I'll share some of the fascinating research we're funding, and finally, I'll discuss a framework for NINR's next strategic plan, which is currently under development. So first, let me begin with a note about nurses and nursing. Nurses have been essential for helping the nation through the ongoing COVID-19 pandemic, because very simply, people trust nurses. Nurses consistently rank as the most trusted of all medical professions. And there's a reason for that. Nurses are everywhere, in our hospitals and clinics, in our schools and workplaces, and throughout our communities. Nurses approach prevention, treatment, and care holistically. Their focus is the person, not a disease or condition. And it's that unique perspective which forms the foundation of nursing science and what we do at NINR, where I've been the director for a little bit more than a year now. So that's why our research examines health and behavioral determinants from many different perspectives, from the biology of a person's cells and genes to their whole self, their family and resources, and the community and society in which they live. And it's by bringing these perspectives together that nursing science seeks to understand and address this whole picture of health and inform practice and policy. So allow me to provide a bit of an overview of NINR's research portfolio, and you'll see how the mission of the Institute dovetails very nicely with behavioral and social science research. Most of NINR's research directly involves people. In fact, over 75% of NINR's funding supports research that directly engages human participants. We're at the cutting edge of research to mitigate disparities in health outcomes. At present, some 32% of our funding focuses on research to eliminate disparities. About 16% of NINR funding supports research to improve women's health. And very importantly, we're committed to funding underrepresented minority scientists. According to data from a recent NIH study, over 75% of the applications submitted to NINR focus on topics on which African American investigators disproportionately apply. That's the second highest percentage at NIH. And in terms of research value, more than a third of NINR's budget supports research on preventing chronic diseases, helping people stay healthy, and reducing the risk of future illness, which is very much behavior-oriented and must be informed by the social sciences. Over 1/2 of NINR's prevention portfolio include a randomized intervention, which is a much higher proportion than at NIH as a whole. And as you know, the randomized control trial is one of the most powerful tools in research. We're focused on preparing the next generation of nursing scientists. As a percentage of our budget, NINR commits more support to training new and early career scientists than nearly any other NIH institute or center. So much of our research effort is aimed at impacting the current health and healthcare landscape, and the current situation is dire. The country faces large and persistent health inequities resulting from the historic and contemporary impacts of racism and other structural inequalities in our society. In this landscape, with gaping disparities in outcomes, we urgently need practice and policy solutions that make a difference in people's lives, their living conditions, and in their health. And if there was ever any question about the need to address pervasive health disparities and their root causes, the COVID-19 pandemic has certainly put it to rest. Data on life expectancy during the pandemic are all that's needed to illustrate this. In one study, COVID-19 was associated with an estimated 1.3-year reduction in overall life expectancy in the United States. This is, a startling and tragic statistic by itself. But even more alarming is that when compared with non-Hispanic whites, the reductions in life expectancy were twice as large for the Black population and over 3 times as large for the Latinx population. In fact, improvements in life expectancy among African Americans in recent years have been significantly eroded due to COVID. And the Hispanic and Latinx advantage in life expectancy has been swiftly erased. Other data with American Indian and Alaska Native populations show equally troubling impacts. We simply can no longer wait to identify scientific solutions to eliminate such health disparities. So I'd like to walk you through some of our important recent research and then explain why it's more important than ever for us to be bold and willing to take risks. We fund innovative research aimed at improving people's lives. NINR-supported scientists have made outstanding contributions to science and health for many years, including understanding determinants of and disparities in many different health behaviors and health outcomes across the lifespan, and identifying effective interventions. One of the strengths of nursing science is its focus on individuals and entire communities and populations across clinical and community settings. This makes us ideally suited to examine both structural inequities and the impact of social determinants of health, or the conditions where people are born, live, learn, work, play, worship, and age that affect a wide range of health outcomes. For example, NINR-supported investigators have examined how living conditions, such as the amount of green space where you live, affect health. In one study, greater residential tree canopy cover was associated with lower perceived stress in low-income pregnant women in urban environments who had a history of depression or anxiety. Another study investigated associations between neighborhood green space and brain-based MRI measures and potential effect modification by apolipoprotein E genotype, a risk factor for Alzheimer's disease. That study provided some evidence that greater green space was associated with less ventricular enlargement. And housing itself is an important indicator of one's living conditions. In this area, one study recently funded by NINR is examining the impact of housing vouchers on children's healthcare usage among low-income families. The research team will use a unique linkage of administrative housing data with Medicaid claims and encounter data. The study will investigate whether the receipt of a housing choice voucher is associated with changes in Medicaid enrollment, and whether children whose families receive a housing choice voucher have different patterns of hospitalizations, emergency department visits, well child visits, and housing sensitive conditions such as asthma, mental health, and injuries compared to those on the wait list. Our research portfolio spans life stages from childhood to pregnancy through older adulthood. In the area of child health, NIR-supported scientists are examining health impacts of early life and childhood adversity. One recently funded study is examining the impact of adversity assessed at multiple time points between 28 weeks gestation and 3 years of age on accelerated biological aging, including telomere erosion and epigenetic aging clocks. So again, this is across the first 3 years of life. Another team is studying patterns of adverse childhood events occurring across childhood and adolescence and their effect on adolescent biological stress, psychological distress, and telomere length. That study has already shown that stress and immune biomarkers, such as salivary and hair cortisol concentration, are higher in Black adolescents compared to white adolescents. But they found no evidence that economic adversity at either key developmental periods or cumulatively explained those disparities. Now, in the area of maternal health, we're supporting work focused on understanding a variety of factors that contribute to racial and ethnic disparities and severe maternal morbidity. One study has found that severe maternal morbidity has increased across racial and ethnic groups, but that comorbidities, cesarean birth, and other factors did not fully explain those disparities. Additionally, this study found that the rates of severe maternal morbidity, which are highest among Black women, might have been reduced had Black mothers given birth in the same hospitals as white mothers. Their more recent project is focused on understanding how social determinants of health across multiple domains, such as structural inequality, community resources, and healthcare access, contribute to risk and disparities. Interestingly, they're also testing the impact of 3 quality improvement collaboratives on disparities in severe maternal morbidity. We're supporting research that examines chronic conditions in older adults. Developing feasible, effective, and scalable interventions to improve health among people with multiple chronic conditions is urgent. However, research gaps hinder intervention development. Most interventions do not consider co-occurring functional limitations, family caregivers' perspectives, or social determinants of health. Moreover, interventions commonly focus on deficits rather than strengths. These limitations are compounded by a lack of communication among practitioners and people experiencing multiple chronic conditions about their goals, their values, and their preferences. NINR is supporting the Hopkins Center to promote resilience in persons and families living with multiple chronic conditions, or the Promote Center, which is poised to address these gaps. And like all NIH institutes right now, COVID-19 is one of our highest priorities. NINR is contributing to an NIH-wide effort to understand the social, behavioral, and economic health impacts of COVID-19 in vulnerable and health disparity populations. One study is examining whether an intervention in South Carolina for both African-American COVID-19 survivors with underlying chronic diseases and their informal caregivers is effective in improving health and quality of life for both partners in the dyad. The intervention will focus on overcoming racial and pandemic-related stressors in the context of community social vulnerability. Another study is examining whether intensified community referrals to address social needs of patients as part of their discharge from an emergency department setting improves general health and COVID-19 related health outcomes. In addition, we're supporting a longitudinal study in New York City. With a focus on disparities, this study will examine health and education changes among children 2 to 4 years after the pandemic onset, and the role of neighborhood and school resources in exacerbating or mitigating these changes. And as my last example, we're supporting a community health worker intervention to improve physical and psychosocial functioning in older, primarily African-American adults in Detroit. The intervention will target self-management and resilience at the individual level, social support at the interpersonal level, and enhanced health department capacity at the community level. So as we move forward, how best to address health issues that plague our nation, how best to combat health disparities, and how to give all Americans an equal shot at a healthy and productive life. A recent report from the National Academy of Medicine makes the compelling case for nursing to assume a leading role in eliminating the persistent health inequities. And we absolutely agree. Moving forward, nursing science can and must have an even bigger impact in identifying solutions to end health disparities, including disparities the pandemic has exposed and continues to exacerbate. That's why we're building on our work in all these areas to strengthen NINR-supported research in health equity. As part of our evolving approach to nursing research and continuing to increase its impact, NINR is in the process of updating its strategic plan, which will assume a major role in steering research priorities over the next 5 years. We recently sent out for comment our new strategic plan framework. In it, we envision a necessary shift in NINR's priorities to address health disparities that affect so many. The strategic plan framework includes a set of guiding principles that we believe should drive all areas of NINR-supported science, 5 research lenses that describe 5 broad perspectives by which to examine health challenges, and strategic imperatives that will be developed on an ongoing basis as new health challenges and new opportunities are identified. So NINR's guiding principles describe important qualities that we believe all of the work that the Institute supports should have as we move to the future. In considering awards for funding, the extent to which studies reflect these principles will be a factor in our decisions. We need to support research that's high impact, applies rigorous research methods, has the potential to significantly improve health well beyond the initial study population and sample, advances equity, diversity, and inclusion, addresses today's challenges and helps us to be better prepared for the future, and provides solutions to optimize health across clinical, community, and policy settings. Those are the broad principles that should frame our entire research and training portfolio. So I'll now move to the research lenses. What do we mean by a research lens? Simply put, by research lens, we mean a perspective by which to examine an identified health challenge. The field of nursing science is comprised of many, many different perspectives on what topics nursing science should address and how we should do so. The framework presents 5 research lenses that we believe best describe our view of the areas NINR support can have the biggest impact. So let me tell you briefly about these research lenses. The first lens is health equity. We want to support research that produces the evidence needed to reduce and ultimately eliminate the systemic and structural inequities that have placed some population groups at a disadvantage in attaining their full health potential. We also want to support research that addresses social determinants of health and how they affect health outcomes. Another lens is that of population and community health, which can address critical health challenges at a macro level by focusing on interventions that affect groups of people with shared characteristics or that live in a shared area. At NINR, we also want to support research that aims to promote health and prevent disease through the continuum of prevention, with a particular emphasis on eliminating health disparities. And our final lens focuses on research to address clinical, organizational, and policy challenges through new systems and models of care, including those that bridge clinical and community settings with social factors and social needs. In sum, our focus at NINR will be funding research that brings new interventions and models of care to where people are. We'll invest in nursing research that identifies novel approaches to address social determinants of health that are at the root of the disparities we see and are essential to address in order to achieve better health for everyone. We believe that these times call for bold action, and NINR is looking to fund science that is poised to rise to the occasion. And before we finish up, I want to tell you about a fantastic opportunity at NINR. We're hiring for a key leadership position at the Institute, that of Deputy Director. They'll help me support NINR in its mission and help formulate research directions for the Institute. They'll collaborate across NIH and with colleagues across the government and throughout the community. They'll be an ambassador for the Institute and even help me reach the community through talks like this. This is a tremendous opportunity for an exceptional scientist to have a national impact. And I hope you'll share this information throughout your networks or even, consider applying yourself. So thanks again for inviting me to speak with you today. Please use the email address here to reach out to us with your thoughts on anything we discussed today. And submit your feedback on the draft strategic plan framework through the provided website by December 13th. And I look forward to your questions and your comments.
Thank you so much, Dr. Zank. I'm Erica Spots from OBSSR, and I'll be moderating the questions. So please do feel free to put questions in the Q&A. We do have one. Someone would like to know if research that includes using medical assistants to deliver behavioral support for patients would be acceptable to NINR.
It certainly sounds like it. Again, our strategic plan is in progress, but if it's consistent with the principles and with the lenses that we outlined, I expect it would be. And certainly we're interested in creativity in terms of how to best improve outcomes and address disparities.
Great. And I, as a program officer myself, I might mention that you'd want to reach out to program staff at NINR or any other institute prior to applying. It's really helpful, and we're not as scary as we seem. Bill, I see you popped on. Do you have questions for Dr. Zank?
Yeah, so Shannon, thanks so much for that. I think one of the things that struck me from your presentation, I'd like you to talk a little bit more about is, I think there's, you dispelled some misperceptions about, one, that NINR is focused primarily on the healthcare system alone and nurses and allied health professionals in the healthcare system, and also beyond the individual to community and population level research. And just wanted to ask about your vision for that, and is that an expansion that you've sort of put in place, or has that been a part of NINR for some time?
Thank you, Bill. Well, I think a strength of nursing, again, are multiple things. One is our holistic and contextualized perspective. That's really central to the field of nursing and nursing science. And then it's also our knowledge and our reach that spans clinical settings, which is what people often think about when they think of nurses, right? We are at the bedside, we are at clinics, but we're throughout the community. We're in schools, we're in workplaces, we're in criminal justice settings, and we're throughout the community. And because of that, our science needs to span all of those areas. And I think what people also don't know or may not fully appreciate about nursing is that, in fact, we do work with individuals to improve their health, but we also care for entire populations and communities. That's part of our role. And so certainly it's part of nursing, it's part of nursing science, and we think it's really important for NINR to embrace that as we move forward.
Thanks, Shannon.
Thanks, Bill. We do have a couple other questions. So this one's a question about terminology. This person is asking if using the terminology of social epidemiology versus social determinants of health would be acceptable to NINR.
Yeah, I might need more information to answer that. And so thank you, Erica, for reminding me, yes, to certainly encourage you to reach out to our program directors. They're there to help and are really excited to talk more about people's research interests. To me, I see no barriers there, but again, I might need more information to provide a better answer.
And then another participant is asking, do you see research opportunities that would not only understand how social determinants affect health outcomes, but also seek to intervene on those social determinants or the mechanisms by which they affect health, and to the program interventions that they might interrupt?
Yes to all of those. My presentation and our framework may not, as of yet, because it is just kind of high level, clearly explain all of that. But especially when it comes to social determinants of health, we need to identify solutions. What are the strategies to interrupt or strengthen for positive social determinants or factors? Strengthen those factors. So we're very interested in observational work as well as in especially intervention research.
That's great. Apparently your presentation was very clear and very informative. We don't have any other questions unless there's some panelists that would like to pop on camera or put some questions in the chat. And if not, I would like to thank you so much for taking time out of your day to present today. It's been very informative and helpful, and we look forward to working with you more in the future. At this point, I think I will turn it over to my colleague, Dana Green-Schlosser, who will introduce our first session. Thank you so much again, Dr. Zhang.
Thank you.
Hi all. Again, thank you guys for being here at this year's BSSR Research Festival. This is our third session of the festival, the first one for day 2, and it is going to be about spatial and structural influences to pay attention to. As you know, from especially through the last couple of years, we've really gotten to appreciate the fact that our location and where we live and how we live certainly does play a big impact in our health, especially when we're in that place all the time. Our first speaker today will be Dr. Dustin Duncan. He's an associate professor from Columbia University, and he's going to be talking about applications of geospatial methods in population health and health disparities research. I'll go ahead and give the floor over to you, Dr. Duncan.
Thank you very much. I'm excited to be here at today's Behavioral and Social Science Research Festival. Broadly, I'm going to talk about how geospatial methods can be applied to study neighbors and health. Next slide, please. After talking about an overview of neighbors and health with a focus on geospatial methods, I'll provide the exemplar of one exemplar study from our lab, looking at the geographic density and uptake of PrEP among young sexual minority men. I'll focus on the methods and results, and I'll spend a fair amount of time thinking through the future research directions. Next slide, please. So first, I want to talk about neighbors and health. Next slide. What we try to do in Neighbors in Health is isolate what I and others call the quote unquote neighborhood effect. We're looking at the effect of a particular neighborhood characteristic, for example, neighborhood PrEP clinics, on a health outcome and or health behaviors, for example, current PrEP use, accounting for a wide range of factors, such as individual, network, and neighborhood factors, to make sure this association is robust, i.e. not spurious. Next slide, please. My colleague and I, my postdoctoral mentor and long-term colleague, Chiro Owachi, and I wrote a book in 2018, or co-edited, Neighbors in Health, where we summarize the state of the field. Next slide, please. In our book, we highlighted several key articles, including an article led by Mariana Akea from MIT, where she and her colleagues did a literature review on neighbors' effects on health. They picked out several key aspects. One, the study design and neighbor definition. Perhaps not surprisingly, the vast majority of studies, unfortunately, on neighbors in health use a cross-sectional design. We know from our basic epidemiology courses the limitations of that. The other issue is that the vast majority of studies use administrative neighbor definitions, half of which use census tracts. Next slide, please. The field of neighbors in health is certainly growing, looking at neighbors with a wide range of health outcomes and health behaviors. There are even fewer studies that look at neighborhoods on minority health and health disparities. Most of those studies focus on socioeconomic and racialized health disparities. Even less work is focused on sexual and gender minorities. And unfortunately, fewer work has considered an intersectional perspective, considering racial and sexual minorities as an example who are also racial minorities. Next slide, please. So now I'm going to talk about geospatial methods in neighbors in health research. There are three objective ways we could define neighborhoods. One, administrative neighbor definitions, including counties, zip codes, and census tracts. Two, buffers around a location, usually around a home. Three, activity spaces, which I'll describe in a second, including as defined by GPS. And some of that, the leading work in the area actually has been done by Dr. Shannon Zink. Next slide, please. There are two main issues that I'm going to talk about when it comes to administrative and buffer-based neighbor definitions. One limitation is that of spatialist classification. We define spatialist classification as the incorrect measurement of a neighborhood exposure based on the definition used. As you see here, if we define neighbors as census tracts, we would say that people in census tract A do not have access to that park, whereby people in census tract B do. But if you look at the spatial distribution of that sample, that in fact the converse is correct. Next slide, please. We've demonstrated this visually in the American Journal of Epidemiology. Next slide, please. As well as empirically. Next slide, please. The other issue is that of the residential trap. The residential trap refers to the exclusive focus on the residential environment. However, as you can imagine, individuals, especially pre-COVID pandemic, spend time in various neighborhoods. So for example, from home to work, maybe people may drop their child at school, maybe after work, maybe someone may go to get a drink with a friend, and then between work and home may go to the supermarket or grocery store to shop for their families for dinner. Next slide, please. So this idea of spatial polygamy or spatial mobility was originally argued by Indiana University's John Odlin and recently reintroduced to the public health literature by Penn State's Stephen Matthews. Next slide. So it's the idea that where we live matters, where we work matters, play and socialize as well as do errand and shops. And just keep clicking the next slides because it shows pictures for each one of those. The other thing is that it also highlights that the commuting corridor or the pathways between these distinct locations may also matter for exposure assessment. Next slide, please. So we wanted to assess this in a sample of sexual minority men. We asked them where they lived, where they socialized, and where they had sex in the past 6 months. Some participants said specific locations. Some participants said general boroughs, which are counties in New York City. And so to maximize data, we aggregated everything up to the neighborhood, the borough level. We found that 75% of participants did not live, socialize, and have sex within the same neighborhood. Next slide, please. One way to address this is GPS methods. Next slide, please. And from the GPS methods, we are able to look at mobility where people go. Next slide, please. We've also demonstrated this the feasibility of collecting GPS methods, but also demonstrated that participants are quite spatially mobile. So you see this participant there. We intentionally obscured their zip code, their mobility data within that zip code, but we see that they do spend a fair amount of time outside their zip code. We demonstrated this in a sample of young sexually minority men. Next slide, please. Multiracial, and we've also demonstrated this with Black sexually minority men, including those in the South. And do you see the map on my farthest right of New Orleans? We see the participant zip code is further south, and we see lots of orange dots. The darker the orange hue, the higher the density of points, meaning that participants spent more time there. And you can see the participant in New Orleans spent a lot of time in the north of their zip code, which is the French Quarter. Next slide, please. And just a little bit more about GPS. It refers to one way to address these limitations that I previously mentioned are by looking at activity spaces. And they refer to the set of locations visited by an individual over a given period of time. And again, GPS methods allow us to track one's mobility in real time. Next slide, please. And essentially GPS devices use satellites image to look at one's geographic coordinates, and again, allowing us to look at mobility and therefore then creating activity spaces. Next slide, please. There are many different protocols that we've used. I'm just going to give you an example of a simple protocol that we've used. We ask the participants to wear their device on all journeys for example, a week period, except when you're swimming, showering, or sleeping. We ask them to charge it daily and complete a travel diary. Next slide, please. There are many common receivers. Next slide, please. As I previously highlighted, this is the device that we've used in our group because we know the accuracy, among other reasons, which we can discuss. It's a Q-Star travel recorder. Next slide, please. Which allow us to get, again, this mobility data. Next slide, please. And this is an example of a real participant. Again, we're able to not just look at their home and create buffers around their home or categorize their sensor tract around their home, but we're able to look at their mobility patterns over a given period and create activity spaces around that. Next slide, please. So now I'm going to highlight one example of a study that we've recently published and conducted titled Geographic Density and Uptake of PrEP among Young Sexually Minority Men, a GPS study. Just a scientific premise. We know that HIV remains a public health problem, especially among sexually minority men. Next slide, please. And we know that PrEP is a HIV prevention mechanism that works. Next slide, please. For example, over 90% effective in preventing HIV acquisition, including in high-risk groups, such as sexually minority men, high-risk heterosexuals, injection drug users, etc. Next slide, please. And while there's been some data that shows that there have been increases in PrEP awareness and use over time, it's definitely suboptimal, especially among sexually minority men. Next slide, please. So now I'm going to highlight the PAT neighborhood study, which was funded by an R21 from NIH. Next slide, please. So what we did is we randomly sampled participants from the existing P18 cohort study from January 2017 to January 2018. Participants had to be HIV negative, had anal sex with or oral sex with a man in the past 6 months, report no mobility restrictions, and be willing to wear a GPS device for 2 weeks. And we essentially used a protocol that we used in our past research. Participants came, they completed a short survey, we gave them $35. They came back to us after carrying their device for 2 weeks, where we sent them text messages, 3 during the week, and they completed, again, a short survey, and we gave them $75. Next slide, please. There were 250 participants in our study where we collected, again, survey data, measured health data, for example, HIV status, GIS data, where participants lived, GPS data, and exogenous Twitter data. Next slide, please. What we did is we got geographic density data on PrEP facilities from CDC's National Prevention Information Network's PrEP locator database, which we've used in a couple of our papers. We had a lifetime and current PrEP use. I'm going to talk about our current PrEP use analysis. We asked participants, are you currently using daily oral PrEP available in New York City? And we control for individual and network factors. Next slide, please. So what did we find? We essentially found that there to be an association between PrEP use and, geographic access to PrEP and PrEP use, especially when we look at activity space neighborhood definitions. Next slide, please. So now I'm going to talk about some of the future research and why this matters. Next slide, please. So there definitely, from my perspective, needs to be more research that looks at contextual factors of HIV prevention and broader outcomes, especially PrEP use, looking at neighborhoods, but also other contextual factors such as networks. And there's a need to really embrace intersectional theory and methods, which I'll talk about subsequently. Next slide, please. So I'm going to talk about our N2 study, which was originally funded by an R01 from NIH and a U11 from the CDC. We subsequently have a NIAID and NHLBI funding to answer other questions in our cohort. Next slide, please. So the scientific premise, we know that HIV remains a public health problem, as I've highlighted earlier, especially among sexual minority men, but there are strong disparities in HIV acquisition, not to mention other continuum of care outcomes, for example, HIV treatment and viral suppression. But we know that about 1 in 2 or 50% of Black MSM in their lifetime will acquire HIV. Next slide, please. We know that Black sexual minority men have mixed awareness and interest in PrEP. For example, in one longitudinal study, PrEP increased from 15% in 2012 to 28% in 2015. Next slide, please. Black MSM also have low PrEP uptake. In one study, 5% of Black MSM report there were PrEP users. Obviously, that varies by study, but we also see significant disparities in PrEP uptake among Black MSM. Next slide, please. PrEP discontinuation is also an issue. In one study, 31% of Black MSM reported PrEP discontinuation. In a study that compared MSM of different racial groups, it found that Black and Latino participants were more likely to discontinue their PrEP use than their white MSM counterparts. Next slide, please. This is some results from our N2 study. Some of the table, excuse me, may be a little bit hard to read, but I'll just highlight one paper led by a former postdoc in our lab. And we found that overall 33% of participants report using daily PrEP use, 14% previously used PrEP use, and about 54% had never used a PrEP. Next slide, please. In our sample, we have about 413 Black MSM in Chicago and about 175 participants in our southern sites, including Jackson, Mississippi, New Orleans, and Baton Rouge, Louisiana. We're collecting various data types: survey data, measured health data, again, GIS and GPS data, but also network data, and newly collecting sleep data. Next slide, please. In our Chicago site, we're collecting data via, or we've identified participants and resampling using RDS methods. In our southern sites, really informed by our CAB, we're using community-based methods, including collaborating with our community partners, flyers, et cetera. Next slide, please. So because we have a longitudinal study, we have longitudinal GPS data, which is a benefit and exciting. Next slide, please. And so what I've done is I've randomly sampled one participant in our Chicago site over, and I presented their data over 3 different waves. We sample every 6 months currently. And so this is the overlapping areas of one participant over that time period. And so we're able to get this longitudinal assessments of where people go and look at longitudinal exposures. Next slide, please. The other issue that I want to highlight overall in the field is global estimates. There's usually a lack of in-person variability in neighbors and health research, which has many implications, including for recall bias. For example, we take the outcome PrEP use. It's possible that PrEP use, unlikely, that it varies on a day-to-day basis. Next slide, please. There are many methods to address that, including EMA, which focuses on what's currently happening in the environment. Next slide, please. This is just one protocol. I won't read it detailed that we've implemented in our group, but we essentially ask participants 4 questions 5 times a day. Next slide, please. These are just some examples of the questions. Are you currently near any healthy food options? Yes or no. This is actually, I think, me when I was participating in our study. It's really to optimize our protocols, where I said yes. Next slide, please. The other issue is the lack of a spatial temporal link between variables. So most neighborhood health studies assume that we know the where, which GPS methods address, and the when, the timing, which EMA methods address. Next slide, please. And really combining methods or geographically explicit ecological momentary assessment really help us to really create that causal link. It can help us understand in real time as they occur, as well as give insights as to where they occur, i.e. behaviors and what's happening in one's contextual environment. Next slide, please. So the field of GEMA is quite new, and there's not a lot of work, especially among sexual minority and gender minority populations. But we have done some initial feasibility work demonstrating that we can conduct these methods. Next slide, please. And just to say that, this is one recent study published by a colleague in our group that demonstrates an initial link between neighbors and PrEP among Black MSM. So in one of our papers, we found, again, the precursor to N2 that, as an example, greater PrEP primary care density was associated with greater PrEP awareness among Black MSM. And we're hoping to do these more rigorous studies like this using GPS, EMA, and other advanced methods. Next slide, please. Just want to acknowledge NIH for our funding, including our recent awards from NIDA and NHLBI, as well as CDC. Next slide, please. And finally, just thank our lab for the work. Thank you all. I look forward to your questions.
Thank you so much for such a terrific talk. As a reminder, put your questions down in your Q&A button at the bottom, and I will read those off. So the first question, it says, early in the presentation, you had addressed neighborhood differences in the use of census tracts versus block groups in the literature. Any recommendations on how to handle small sample sizes with respect to relatively low minority population in small geos/areas?
That's a really great question. I think the first, my first thought would be to think about the conceptual model and your DAG, and think about how that neighborhood exposure may relate to the health outcome. And if it truly is an administrative neighborhood definition, which it doesn't necessarily need to be. So I've tried to highlight that, and a lot of Dr. Zeng's early work shows that that there's a fair amount of variance unexplained when we look at of an environmental exposure, when we look at crude neighbor definitions like administrative areas. So I'd really encourage you to think through whether that administrative neighbor definition is needed or not. But let's say it's needed, and if it's needed, then you would have to have sufficient sample size within that area. So if it means going to a larger unit, then that's that's what it has to be analytically. But I think it's important to to understand the limitations of that neighbor definition, like all research, and just being transparent about that. So my suggestion would be, consider not using that administrative neighbor definition if possible. So something more egocentric, and you have that built-in variation. And if you need something administrative for whatever reason, basically based on the scale or data privacy or other issues, then I would aggregate it up to something where there is significant variation. I hope that answers the question.
Great. The next question is asking about how complete were the EMA data, given the number of items and times per day were they asked to respond?
Yeah, that's a great question. This is more of an overview, so I didn't really dig into that. That was really a feasibility study to look at the quality of responses, and we have another study in the field now where we're looking at the first, I think, 25 to see how participants feel about it, and to see how it is. Participants completed it, but they complained to me and and said it was a lot. And in that study, it was kind of my first EMA study. There was a lot of repetition, and participants didn't like that. So it wasn't interesting to ask the same questions. There was a high degree of response. I don't think we published that paper, but I'm not sure that we would see those same results in the pandemic period where people are perhaps on their phones more. And, I guess I would say, what we're doing now, I'll say what we're doing now. What we're doing now to be mindful of the participant burden, which we're exceedingly mindful of now, especially, is we're doing 2 times per day, and we're also making sure there's a limited number of items and being really thoughtful about the items, and also thinking about the variation of the items to make it more interesting to participants. But if you have in all of my studies, I've tried to be a participant in them. So I've worn our devices, I've followed the protocols. EMA is not an easy pill to swallow. It's a lot, and it's overwhelming. It was overwhelming to me. So we are trying to continually get the best data, but also being mindful of the participant experience and especially not trying to burden our participants. But I can share with you any of our protocols. We have a couple colleagues from Hunter College and from Rutgers who are helping us optimize our protocols and implement it, who are more established EMA experts.
I know that's a difficult question and always a tough balancing act. The next question, the person comments that you had a great, very interesting presentation, and that they think many researchers use administratively defined definitions of neighborhood because the data are easy to obtain, but also because these geographic areas have policymakers and that represent the people that live in the area.
Yeah.
What are your thoughts about how we could use these methods to help inform policy change that might impact the multiple environments that people spend time in?
That's a great question. I think it really speaks to the research question. So if the research question is about what's the causal association between a neighborhood exposure and a health outcome, I do think using something more nuanced like activity spaces or buffers make the most sense. I think that if we're looking at a policy level question, for example, the distribution of an amenity and looking at disparities in that, then I think that using a policy or administrative neighborhood unit does make sense. In chapter 1 of Neighbors in Health, Achiro and I really tried to dig deep into not only neighbor definitions, but when we should use one. We try to be a little bit, provides a little bit of guidance on when we should think about using one neighbor definition versus another. But my response is, really when we're looking at an individual exposure, we should really use the most nuanced neighborhood measures as possible for the issues that I mentioned, but mainly misclassification. I think there's a significant amount, and sorry to keep highlighting Shannon Zing's work, but it's really been formative to mine. And also it just really demonstrates, especially when I was a fellow and a new faculty member, that we really should be mindful about the neighbor definitions, one, and really avoid administrative and crude neighbor definitions when possible. But I agree, I think it's difficult, it's not easy. We are, like many research groups, have adapted our protocols because of the pandemic. And, we would give participants GPS devices. That was what our protocol, but we're actually going to stop doing that because it's difficult to mail participants GPS devices, have them mail it back. And so actually we're in a phase where we're collaborating and deciding on what app or what app to use or to develop. We have a couple things that we're thinking about in our group, largely or specifically, but also within our department, and a couple of colleagues in the field who I've been communicating with to decide that. But I agree. I think a lot of times people use administrative neighbor definitions because it's easier and it's readily available. Which doesn't mean that it's not important. I think everything depends on the question that we're asking. But yeah.
Great. Well, thank you so much. And thank you for such a great talk. I'll pause for 1 minute to see if there are any panelists that have any questions they'd like to ask. If so, unmute and ask. Okay, if not, I just want to again thank you for your great presentation, and I will go ahead and get started with the next one. So the next speaker that we have is Dr. Ethan Marish, who is an associate professor at American University. And they're going to talk about daily associations between minority stress, craving, affect, and nicotine use among sexually minority youth who use nicotine. And I'll go ahead and let you take it away.
Thank you. And thank you for OBSSR for the invitation and including me in this year's festival. I'm really honored to present and to present with so many great scientists in the field. So to begin, I have no conflicts of interest to report and would like to acknowledge NIAAA for my Career Development Award, as well as NIHD for funding this specific study. So We know from decades of research that there are sexual orientation disparities in substance use outcomes, in willingness to use substances, misusing, and developing dependence, where sexual minority youth, being gay, lesbian, bisexual, queer, and other sexual minority youth, are more likely to use substances compared to heterosexual youth. Within the context of nicotine or tobacco, we know that sexual minority youth are more likely to use nicotine products like cigarettes, e-cigs, smokeless tobacco, vapes, and so forth. They initiate at younger ages, smoke more frequently, and more likely to develop nicotine dependence compared to heterosexual youth. Despite this compelling evidence for this health disparity, our understanding of factors that explain this heightened risk remain poorly understood. Next slide, please. One model that helps us understand some of these disparities is the minority stress model. And I'll go into that in just a moment, but in general, we know that stress is a major contributor to the initiation, maintenance, and relapse of nicotine and other substance use. Stress and the association between stress and substance use is especially pronounced for adolescents, given it's an important developmental period. For sexual minority youth specifically, the experience added and unique stressors called minority stressors. So what the minority stress model posits is that we all experience general stressors regardless of our identities and statuses, and these stressors relate to different health outcomes based on our coping and social supports. Can we go back to the prior slides for a moment, please? Thank you. And so the minority stress model posits that sexual minority youth experience unique stressors called minority stressors, such as experiences of discrimination, harassment, and bullying specific to their identity. And we know that would be related to their health. There are other minority stressors like having to conceal one's sexual orientation, internalized stigma, or anticipating stigma are also stressful. But for this study, we focused on external experiences in the social context like discrimination, harassment, and other factors. Next slide, please. So we know that these types of stressors are actually pretty prevalent in sexual and gender minority youth's lives. So we have studies that show for example, almost all sexual and gender minority youth report hearing homophobic remarks at school in the past year. Almost about 87% report hearing transphobic remarks. And many are targets of verbal harassment specifically related to their sexual orientation or gender expression. In addition to verbal harassment, there are now about 90% of sexual and gender minority adolescents experience victimization, bullying victimization related to their identity in their lifetime. So these experiences are quite prevalent, but they're understudied when we think about the day-to-day experiences of youth. Next slide, please. So going back to the minority stress model, we know from past couple of decades of studies that digital minority stressors, so experiencing harassment or discrimination, particularly related to one's sexual orientation, is associated with greater nicotine use and dependence. Next slide. However, there are limitations in this body of work. So the majority of studies are cross-sectional. And so we need more longitudinal and daily diary studies to really understand how these associations unfold over time. The other limitation is there's a dearth of research examining within-person variability in minority stressors and how those relate to fluctuations in substance use among adolescents and youth. So many of the cross-sectional and the limited longitudinal studies show at the group level that experiencing minority stress is related to greater nicotine use. But what we don't know is how within-person associations unfold over time. So specifically, if for bisexual youth, if they experience more minority stressors than they typically experience on a given day, is that related to greater nicotine use for that particular day or moment? The other limitation is the lack of work examining momentary mechanisms that could explain the associations between minority stress and substance use. So thinking about mediating mechanism that could be targets of intervention that could help explain the associations of minority stress and nicotine use. Next slide. So one particular mechanism could be craving. So we know in general from the addiction field is that craving is a hallmark feature of addiction for nicotine use, nicotine addiction or other forms of substances. And craving is one of the most common symptoms of nicotine dependence on youth, and is a risk factor for relapse. Now, there's very limited work looking at minority stress and craving in general among sexual minorities. But recently within my lab, we published a study, an experimental study showing that minority stress elicits craving amongst young sexual minority adults who are heavy drinkers. So craving could potentially be one mechanism. Another mechanism could be affect. Next slide, please. So we know that affective processes are also integral to addiction and are especially salient for youth. So several addiction models, such as negative or positive reinforcement models, indicate that negative and positive affective states are precursors to substance use. And so individuals can also potentially use substances to alleviate negative emotions or enhance positive affect. Next slide. So putting it all together, the aims of this study were to examine within-person and fine-grained momentary associations between minority stress and nicotine use, and to examine craving and affect as mediating mechanisms of those associations. So to conduct the study, we leveraged ecological momentary assessment, and Dr. Duncan explained what EMA was about, so I'll keep that brief. But we leveraged EMA over a 30-day monitoring period to assess these momentary associations in the lives of sexual minority youth. Next slide, and the following one, please. Thank you. So to conduct the study, we included participants who were between the ages of 14 and 19 years old who identified as a sexual or gender minority, and the entire sample are sexual minorities. They needed to be an active nicotine user, so using nicotine 4 or more times in the past week, so using 4 or more cigarettes or vaping or other types of nicotine they might have used. They've experienced 3 minority stressors in the past 30 days, as well as able to read English. And we excluded participants who were currently in smoking cessation treatment programs, because the study was more an observational study of nicotine use and minority stress. And we also included actively psychotic or suicidal participants. Next slide. So to recruit participants, we utilized several forms of recruitment through social media, going into the community, going to events where queer youth live and attend. So all participants were recruited through the community to participate in this study. We first did phone screenings with them and then invited them to the lab to participate in the study, where we did additional screenings, as well as had them do some self-report surveys, as well as interviews, in addition to training in the EMA protocol. So then they went through an EMA protocol of 30 days, and I'll go over that in just a moment. And then they returned to the lab for additional surveys and interviews. Next slide. So our EMA in general is a really useful methodology to assess momentary associations among participants' lives. For us, we used an app that we had participants install on their phones to make it easy for them to use, given that youth are often on their phones. And so participants engaged in the app in 2 ways. One, the app prompted them to complete surveys, and the other ways is asking participants to enter surveys, specifically nicotine reports, when they right before they started to use nicotine. So there were 4 different types of surveys. They received a daily morning survey, a random prompt, a bedtime report, and nicotine reports. The random prompts and nicotine reports are what I'm presenting in this presentation. So the random prompts were randomly prompted throughout the day, 5 times throughout the day over 3-hour blocks. Participants received a notification on their phone, as well as a text reminder, and they had 30 minutes to complete those. And those asked about minority stress, affect, craving, and substance use. And participants received monetary incentives for participation. Next slide. So in general, in total, we enrolled 85 participants, 10 withdrew for various reasons. The mean age is about 18 years old. About 70% of the sample were assigned female at birth. We had some gender diversity, but about 60% cisgender females. And a third of our participants were in high school, and 2/3 were about in college, and about 16% received family public assistance. Next slide, please, and the following one. So we used, I'm just going to go over briefly some measures we used. So we used an existing minority stress measure developed for experience sampling in EMA studies. So participants were asked, for example, do they feel uncomfortable or unsafe since the last report they completed? And then were prompted to indicate which identities they attribute that to, their sexual orientation, their race, or other identities. Next slide. We also assessed craving, affect, so craving and affect in the moment, as well as substance use, nicotine and other substances. Next slide. So we used multi-level structural equational modeling to test our research questions. So we looked at both within and between person associations, but I'll mostly focus on the within person associations since they're more interesting. But we looked at minority stress. So since the last report, how that predict our current affect and craving, and how current affect and craving predict use, specifically nicotine use, at the next report. So we temporarily ordered our constructs in a way that we can test mediation in a rigorous way. Next slide. And the next one. Thank you. So in terms of our results, just briefly about the EMA period. So we had about almost 6,000 random reports completed and about 2,200 nicotine reports. Participants contributed almost 3 to 30 days in the study, depending on their compliance, and on average, about 26 days. Next slide. So about 12.6% of random reports, minority stressors were endorsed. And of next reports, nicotine use was endorsed about 57%. 57.3% of the time. So nicotine use was very actively, participants were very frequently using nicotine throughout the study. And the most endorsed way of using nicotine was vaping, followed by cigarettes and e-cigs. Next slide. So just to highlight the main findings. So in considering affect first positive, then we'll go over negative affect. So what we found is in the moment exposure to a minority stressor was associated with momentary decreases in positive affect. And we found that positive affect was associated with greater probability of nicotine use at the next report. Next slide. In terms of negative affect, oh, and I forgot to mention that for positive affect, the mediation that path was significant. For negative affect, we found that in the moment exposure to a minority stressor was associated with greater elevations in negative affect, but we did not find associations between these negative affect domains and nicotine use. Next slide. And finally, in terms of craving, we did find that in the moment exposure to a minority stressor was associated with elevations in craving, and these elevations in craving were associated with nicotine use at the next report. So next slide. So putting all these findings together, so just to summarize, we found that momentary minority stress was associated with greater nicotine craving as well as greater negative affect. It was associated with lower positive affect. And associations between minority stress and subsequent nicotine use within a day were mediated through craving and positive affect, but not negative affect. Next slide. So just to provide context to these findings and their limitations, one is the study was conducted in one metropolitan city in the US, and so there are obviously limitations in terms of generalizability to other regions in the US that could be more could have more stigma or experiences of minority stress. The sample was primarily white, about 70% of the sample were white, and we had limited numbers of cisgender boys as well as gender minority participants. So the generalizability of our findings are limited to our sample. And then lastly is, although we established a temporal order among assessments to rigorously test our mediation questions, the correlational nature of the study limits its inferences of causality. But just thinking about the overall implications and future directions, so our study clearly identifies minority stress as well as craving and affect as risk factors for nicotine use in the moment nicotine use for sexual minority youth. So really thinking about how to target and assess minority stress in the daily lives of sexual minority youth to help potentially decrease their nicotine use. So that can include treatment interventions targeting specifically minority stress and these addiction-related mechanisms like craving and affect, but also in the moment interventions, like using ecological momentary interventions where participants could be, based on their responses to minority stress or nicotine use, could immediately get brief intervention to do in their own home, for example. Next slide. So just to wrap up, I just want to acknowledge again NIHAA and NIMHT for their generous funding, the participants of this study, as well as my collaborators on this study who helped make this happen. So I'm happy to take questions and comments at this point.
Thank you so much for a wonderful talk. While I'm waiting for some questions to come in through the Q&A, I want to open it up to any of the panelists if you have any questions that you would like to ask regarding this, the research that was just presented here. If so, just unmute and pipe up.
Sure, I don't mind. This is Dustin.
Great.
Nice
Go ahead, Dustin.
I'm just curious. One great talk, and I really love to see the EMA proportion. I think that that's so innovative and so important. And I strongly believe that the global estimates that we get are problematic for many, many reasons. I mean, we talk about recall, but I think there are many other reasons. I just think that there's inherent variation in the things that we do. So my question is, moving this observational work to like an EMI framework, can you walk me through like what an example ecological, momentary intervention could be? I struggle with that a little bit, and to my work, or with respect to my work, especially like thinking about the geographic component to it. So I would just love to hear your perspectives on what potential EMI, basically the next generations of your work, thinking about the intervention implications of it.
Yeah, thank you for the question. Potential EMI interventions they could look like is keeping a similar assessment design as a study in terms of asking about the minority stress throughout the day or from day to day. And when participants might endorse a stressor, an app could then suggest different coping skills to deal with that stressor to help mitigate its effects on their substance use or other health outcomes. From stress management techniques to assertiveness or advocacy techniques, excuse me, as one potential way. And the other pieces could be, if they're active nicotine users, ways to manage their craving or to prevent additional nicotine use if they're stop smoking, for example. So that's potential one way. Another thing we've been thinking about in my lab and with my colleagues is actually connecting to your work, Dr. Duncan, in terms of we were thinking about how to connect geographical location to one's experiences with minority stress. So are there hotspots where someone might experience more minority stressors than they typically experience? And if so, there could be interventions that could help participants maybe prepare before they enter those spots, as well as how to deal with stressors when they are in those locations. However, we haven't been able to collect GPS data since these were youth and for various IRB related reasons, but we would love for that to be a next direction as well for our work.
Thank you very much.
Great, and now we have several questions that have come in. So to what extent do you think having to report every time they use nicotine influenced how often they use the nicotine?
That's a good question. EMA methods have been used in substance use research for decades. And have been used well. They don't typically, based on prior work, as well as our analyses, they don't typically impact use. What potentially could be impacted is just participants not reporting as much use as they are actually using. So from my experience with the EMA work, it doesn't typically impact more use or less use. It's participants will continue use in some ways regardless of our assessments or other studies assessments.
Great. The next question was, well, they're thanking you for your work and presentation. And they mentioned that both of the presentations, both yours and Duncan, had made them think a great deal about the burden and data accuracy of EMA and how to create better protocols. And yes, the EMI is really interesting too. So I think that's more of a statement than a question.
Okay, thank you.
Then the next question was, they were curious if you had examined the different types of minority stressors, vicarious experiences, and the relationship to your mediators and or outcomes. Do you see youth reporting more direct or vicarious experiences?
Thank you for the question, a really important one. Our assessment of minority stress, we asked them about 9 different minority stressors, and one of those items is vicarious exposure to minority stress. And that one is often the most endorsed stressor compared to the least endorsed one is actually experiencing violence or physical harassment related to one's identity. Due to just the low frequency of endorsement of minority stressors overall in our monitoring period, we looked at them all together, not separately, but I think with larger samples and more variability, it would be really important to discern how different stressors can impact substance use and other health outcomes.
Great. We have 2 last questions. One is, this is a high-risk population, so in so many ways, and the results are impressive. Minority stress and effects on development risk behaviors, etc., are profound. You and Dustin have discussed participant burden. Did you find any relationships between participants' monthly minority stress levels and the rate of EMA responses? And they also have down in parentheses, is it also possible that EMA queries could serve as a quasi-therapeutic moment of connection to queer, if perhaps unknown, others?
Thank you for that question. We haven't tested how reporting minority stress impacts compliance, but I do think that is an important question that hasn't been tested, and at least I'm not familiar with other studies that have, but I think we are actually in the process of revising. We've submitted this paper for publication and in the process of revising it given that we've received a revise and resubmit. And we actually received a very similar question around that. So we're hoping to conduct some additional analyses to look at how reporting of minority stress might impact compliance over time if maybe youth just start to disengage from the study, if they experience a lot of minority stress. We haven't tested those questions, but if you reach out, maybe in a few weeks, we'll have an answer. And I can't remember the last part of the question, but I think it was, if it's therapeutic to ask, to report. In terms of answering that, we do interview participants at the end of the study, and we've asked them, how does asking you about your identities and stressors impact you? And most participants have reported either neutral or somewhat positively. So far, we've received feedback that it doesn't impact them much, but can't say confidently. Obviously, those are, I think, good empirical questions to examine. So thank you.
And the last question, what are the implications of these results on SGM minorities who live in communities which may have a higher stigma against SGM minorities?
Thank you. I think given, as I said, in terms of limitations, obviously our study is limited in terms of the region. It was a New England city that is more, has more societal accepting attitudes and affirming attitudes as laws. My assumption is in regions where that is less the case, potentially participants were reporting a lot more minority stressors, and those would hypothesize to have more negative effects on their emotional and craving processes, as well as their nicotine use. We do have some evidence, not from my lab, but from others in the field, around structural stigma, so heterosexist policies and laws, so specifically living in states or regions that have more heterosexist policies and laws, that is associated with greater substance use for youth and adults living in those states. So we would probably assume similar findings.
Well, thank you so much for a great talk.
Thank you.
And with that, I'll move on to the next one. So our next presenter, and the last one for this session 3, is Dr. Chandra Jackson. She is with NIEHS, with the NIH, and is an Earl Stadtman investigator. She's going to be talking about the social epidemiology of sleep. I'll go ahead and let you take it away.
Thank you. Hello, everyone. I hope you all are doing well. As mentioned, I'm Chandra Jackson, and I'm delighted to present on the social epidemiology of sleep health equity. And I'd also like to thank both the nominators as well as the organizers for the invitation. This focus on sleep is of tremendous public health importance because, just as an example, out of the approximately 333 million US citizens, an estimated 50 to 70 million US adults have a sleep or wakefulness disorder, including obstructive sleep apnea or insomnia. Sleep deprivation currently costs the US billions of dollars in work-related loss in terms of productivity and healthcare costs per year. Around 60 million prescriptions for sleeping pills are written annually. There are over 320,000 accidents each year attributed to insufficient sleep. And sleep disturbances have been shown to be associated with a wide range of common and unfavorable health outcomes that I'll describe further into the presentation. And unfortunately, major disparities in sleep exist.
Chandra, I just wanted to say you don't have your slides up yet.
Oh, that's unfortunate. Huh. That's odd. Can you see them now?
Now we see them. Perfect. Thank you so much.
Oh, wow. Okay. So, for instance, collaborators and I have shown across various independently important measures of sleep-wake function in socially constructed racial ethnic categories, minoritized racial ethnic groups have been shown to be less likely to get the recommended amount of sleep, and that's at least 7 hours of sleep per day. There's also evidence of lower sleep efficiency across minoritized racial ethnic groups in general, with sleep efficiency considered spending at least 85% of one's time in bed actually sleeping when that's the intention. And where data exists, these groups spend less time in slow wave sleep, which is considered physiologically restorative in terms of, for instance, cellular as well as tissue and growth repair. And alarmingly, these disparities in sleep begin in infancy. So these two figures are a depiction of, at the top, the various stages of healthy sleep over a 9-hour period, including those stages that are linked to physiological and cognitive restoration, along with, at the bottom, aligned circadian rhythms where the human biological clock is in sync with the environment's light and dark cycle. And so both can be negatively affected by inopportune exposure to chemical and non-chemical stressors in the environment, which have been shown to disproportionately burden disadvantaged populations. And so these stressors include, but are not limited to, environmental light, such as artificial light at night, extreme temperatures, noise pollution, poor air quality, poor nutritional quality and suboptimal timing of food intake, pests and allergens, and psychological distress from a variety of sources. All of these factors can lead to disrupted sleep and circadian misalignment, which can contribute to poor mental and cardiometabolic health outcomes, including depression, since certain stages of sleep are associated with mood regulation. Obesity, since when the body is sleep deprived, the stomach hormone ghrelin, which is associated with hunger, is upregulated, and leptin, the hormone associated with satiety, is downregulated. And so while these appetite regulating hormones can act in concert to ultimately lead to weight gain and eventually obesity, poor sleep also has been shown to activate parts of the brain associated with hedonic behavior, including craving unhealthy, sweet, and salty foods. There's also associations with hypertension. And this could be due to the non-dipping of blood pressure, which occurs when nocturnal blood pressure does not drop lower than the 10 to 20% of daytime blood pressure like it does under healthy conditions. There's also associations with type 2 diabetes because sleep deprivation can rather acutely contribute to insulin insensitivity and glucose intolerance. And also cardiovascular disease because of higher levels of inflammation and oxidative stress resulting from sleep deprivation. And so in the next few slides, I'll provide examples of some of our studies related to artificial light at night, air quality, as well as psychosocial stressors and their association with sleep. And so in this prospective analysis, we essentially found a dose-response relationship between exposure to artificial light at night while sleeping and obesity risk among a racially diverse group of women. And so this relationship is biologically plausible because exposure to light at night could lead to hormone dysregulation. And I wanted to highlight that Black women in this study were the most likely to report sleeping with a light or television on in the bedroom at 36% versus 18 and 9%. So Black women have the greatest exposure burden, and these findings can translate actually into an easy, low-cost intervention to help address obesity. And as another example with real-world implications, we leveraged data from the late environmental scholar and activist Steve Wing at UNC. And we investigated air emissions from swine industrial livestock operations and sleep health. And so this study was conducted among 80 residents in 16 nearby residential, largely African-American communities here where I am in North Carolina. And the relationship is important because although it seems abstract, air emissions containing, for instance, hydrogen sulfide, ammonia, and particulate matter can contribute to a cascade of biological effects, including compromised lung function, but also poor mood and distress, which can all influence sleep. So based on repeated measures from 14-day diaries and a monitoring device, we found that nightly swine odor was associated with lower nightly sleep duration, and that hydrogen sulfide detection was associated with more sleep awakenings. And so these findings essentially underscore the importance of emissions reduction and odor abatement as important public health goals when designing technology solutions to waste management. Considering the impact of racial differences in residential environments on sleep, in a nationally representative study where we analyzed data from the National Health Interview Survey, we investigated sleep disparities among racial ethnic groups living in public housing or not, and essentially found no disparities in very short and short sleep between non-Hispanic Black and non-Hispanic white adults who both resided in public housing and essentially within similar physical and social conditions, which is, as other speakers have mentioned, pretty rare in the United States due to racial residential segregation caused by structural racism. And so these findings of no disparities when groups lived under similar conditions strengthens the case that disparities would likely not exist if groups had the same access to health promoting environments and the same protection from hazards. And so I just described the residential environment as a determinant and the work environment is another. In fact, showing the healthcare industry as an illustrative example, we found that the Black-white disparity in the prevalence of short sleep across certain industries of employment was evident across all categories of occupational status. And the disparity was surprisingly widest at the professional or management versus laborer category of occupational status. And this opened a new line of sleep research, leading to these findings being corroborated by other research groups. And we've also recently completed a mixed methods project as a follow-up to this study, and we'll be publishing the findings soon. And so considering stress as an important determinant of sleep health and acknowledging that discrimination on the job may be an important contributor to sleep disparities, we investigated these associations among women. As an example, reports of race-specific job discrimination were associated with greater odds of sleep difficulty, and that is trouble falling or staying asleep, while other forms of discrimination were generally associated with reports of excessive daytime sleepiness. And so a particularly novel finding related to intersectionality, which both speakers mentioned, was consistent with our hypothesis in that we found a dose-response relationship between the number of marginalized identities for which the participants perceived discrimination, and these were associated with an even higher odds of sleep problems in comparison to participants reporting fewer sources and especially no job discrimination. And so a practical example would be a woman reporting discrimination based on her race, gender, sexual orientation, and having a disability. And so this participant or these groups of participants would have a greater odds of sleep difficulties in comparison to a woman reporting discrimination based on gender alone. And so these findings ultimately raise concerns about sleep health disparities that can emanate from the workplace. And it also underscores the need to employ an intersectionality perspective. So considering stressors across the life course as an important determinant, we've also investigated associations between the pervasive public health problem of traumatic childhood experiences and multiple dimensions of poor sleep in adulthood. And so using data from the sister study, which included traditional measures such as physical and sexual abuse, as well as more novel measures that include natural disasters along with household dysfunction, we essentially found that women with any compared to no traumatic childhood experience were more likely to report short sleep, taking longer to fall asleep, frequent night awakenings, and frequent napping as adults. And so with data not shown on this slide, the magnitude of the associations were actually stronger when the perpetrator of the trauma was regarded as close to the participant. And so mechanisms that we outlined years ago linking childhood trauma to sleep disruption in adulthood include changes in brain circuitry during developmental periods, potentially leading to a higher likelihood of psychiatric disorders that could contribute to disrupted sleep in adulthood, and also simply failure to develop a healthy sleep schedule or routine as a child could carry over into adulthood. So ultimately, this research is aligned with the themes that emerged from this relatively recent NIH workshop on sleep health disparities that I was fortunate to co-chair. And so the themes that were based off of experts from both sleep and health disparities convening, the themes that emerged were the need to investigate the causes along with the consequences of sleep health disparities, the need to develop and promote integrative research on the topic, as well as to develop interventions and build the research infrastructure and training opportunities for sleep health disparities as a pillar of health that should be considered just as important as physical activity and nutrition. And so I'd like to end and thank you for your time and attention.
Thank you so much. Trying to get my camera to stay back on. Okay, so thank you so much for that very interesting talk. We do have a few questions basically about sleep. So the fundamental question is, what is sleep and why do we sleep as humans? Why is it so important?
Absolutely, that's a fantastic question. And I think people may be surprised to know that we actually don't know why humans sleep, in fact, but there's certainly some really strong theories. So I'll first mention sort of the formal, widely accepted definition of sleep, which seems jargon-laden, but again, it's well accepted by sleep scientists. And it's that sleep is a recurring, reversible, neurobehavioral state of relative perceptual disengagement from an unresponsiveness to the outside world or environment. And so it's, as you could imagine, characterized by a state of inactivity or dormancy. There's also decreased responsiveness to external stimuli. And we know that sleep is relatively easy to reverse, especially in the lighter stages. And you'll also be familiar with muscle tone relaxing, and humans, which is actually a species specific phenomenon, sleep in a supine position. And we know that it's species specific because bats, for instance, sleep upside down. And so that's a definition of sleep and how it's characterized. But in terms of why humans sleep, again, these are theories that are becoming stronger based off of investigations from scientists, but neuroscientists in particular. And so we believe that sleep is incredibly important for the entire body, but in particular for the brain, in terms of memory and learning consolidation. And so you could imagine the importance of being able to remember some sort of survival tactics through evolution. And so it turns out the brain prunes synaptic connections and stores the ones that are deemed important to remember for future purposes. And so you could imagine, obviously, that being really important to recall how to save yourself from the last time you were chased by a lion or a bear, for instance. And so that's actually a really strong theory, is that we sleep for the purposes of memory and learning consolidation, but also for the sake of physiological restoration, in terms of there are certain stages of sleep where cellular and tissue growth and repair occurs. The growth hormone is released primarily during sleep. And we know through Nobel Prize winners now that the brain is washed by cerebral spinal fluid during sleep. And so that could be incredibly useful in terms of restoring the biological processes that were used during the day, again, being restored at night during sleep. And then also there's a theory that's not as popular, but we could sleep for energy conservation, but it turns out that we only save about 110 calories by sleeping as opposed to staying awake. And so that's a less popular theory as the ones I just mentioned. But the reality is that we likely sleep for an amalgamation of reasons and not for any one purpose.
And what would you say constitutes good sleep?
That's a great question. And I think it's important to know that sleep is multidimensional, and it's more than just sleep duration, but quality of sleep and timing matters. And so good sleep would entail adequate duration, so at least 7 hours of sleep within a 24-hour period. High sleep efficiency, again, spending at least 85% of one's time in bed, actually sleeping when that's the intention. So you could imagine if you have insomnia and you lay in bed, not being able to fall asleep. So that's a useful way of thinking of high efficiency, in that you actually are asleep when you want to be. And also that the sleep is appropriately timed. So we evolved to sleep when the sun goes down and to remain active throughout the day. And so it is optimal to make sure you are sleeping at appropriate times. And obviously there are structural factors like night shift working that can preclude one from sleeping at night, but that doesn't mean it's not without biological consequence. Also, you should ensure that you have sustained alertness during waking hours, as opposed to excessive daytime sleepiness, which could be a sign of a problem that should be checked out by a physician. And you should also just be generally satisfied with your sleep, which is a reason why we can think about the importance of relying on objectively measured sleep, but we'll always need to also consider if participants or patients are generally satisfied with sleep, which is a subjective measure. And so measured and self-reported sleep will always be important. And then lastly, I'll say, many people think, well, my sleep is fine because I don't have a diagnosed sleep disorder like insomnia or obstructive sleep apnea. But indeed, you'll find that many people could likely improve their sleep based off of the dimensions I just mentioned, but without obsessing over perfecting sleep, because that could turn into a disorder itself.
Thanks, Chandra. This is Alyssa Dold from OBSSR. I'm jumping in because I just heard that Dana's computer may not be working. So another question, for those who may be unfamiliar, can you please describe intersectionality?
Oh, sure. So fortunately, all of the speakers prior to this presentation have mentioned intersectionality, which was coined by Kimberly Crenshaw, the Harvard-trained lawyer, who's also at the heart of the conversation related to critical race theory. And so the way I think about intersectionality is that people, it's an acknowledgement that people do not navigate society in the same manner, and that people can have multiple social identities, gender, race, age, sexual orientation, disability status, and all of those different social identities encompassed in one person could have disadvantages that could intersect and lead to a synergistic level of disadvantage that can affect whatever outcome of interest, whether it's social or in the case of NIH and OBSSR, a health outcome. And so intersectionality is acknowledging that an individual or group of people could sit in the intersection between multiple identities in ways that aren't always acknowledged by structures in society and can lead to substantial disadvantage over and beyond the disadvantage experienced by one marginalized social identity alone.
Great, thank you. And another question here, was there any attempt to distinguish between Latinx individuals who were born in this country and those from other countries as far as potential sleep disruption?
Absolutely. There certainly are researchers who look at immigration status, for instance, and I have done the same. In fact, in the slide describing the disparities, I mentioned that most minoritized groups are less likely to get the recommended amount of sleep, except for Latinos born outside of the United States. And so that's actually consistent with the quote unquote Hispanic paradox, where health outcomes tend to be better when the group has not lived in the United States for a certain period of time, but the longer the group stays in the United States, the worse or poorer the health outcomes become generationally. And so we've found that sleep is consistent with that story. We've also looked at sleep by immigration status in terms of the work-sleep relationship. And so the same one I mentioned in terms of the sleep disparity being widest at the professional category among Black compared to white individuals, the same observation was found for Latinos. I believe it was published in Social Science and Medicine. And we also looked at Asian participants in the National Health Interview Survey and in comparison to white employed individuals. And the relationship I've mentioned was not seen, but the disparity was actually widest among laborers. So it just shows that societal factors can clearly differ by socio-demographic groups.
Thanks so much for that. We have several other questions, but maybe we'll do one more. So you mentioned mental health related to sleep. Can you say more about that? And are you working with a psychologist to study that aspect?
Mental health related to sleep. So it's certainly biologically plausible because it's believed that in general, a certain stage of sleep, in particular, rapid eye movement is associated with, again, mood regulation and also cognitive restoration when the sleep is sufficient and hopefully optimal. And so repeated disrupted sleep has been associated with poor mental health outcomes and mood disorders, including depression, which, right, the definition of depression includes sleep in the, the DES. So there is a close connection that's widely identified. And we've also investigated racial differences in sleep and psychological distress in a nationally representative study. And there have been other investigators who've focused on this topic in particular. And so the evidence is strong across a number of mental health outcomes, but there's tons of opportunity to strengthen the weight of the evidence to suggest that sleep affects mental health outcomes. And I always work with experts. that depends on the topical area. So I hope that response was sufficient.
That was great. Thank you so much. There are a few other questions in the Q&A box, so if you wouldn't mind staying on and maybe answering those directly. And I think because we have lost our moderator, we'll take a little bit of an early break and we'll start the next session at 3:10 p.m. So if everybody could reconvene at that time, we'll give everybody a little bit of extra time and we'll regroup on our end as well. Thanks, everybody. And thanks again, Chandra.
Oh, anytime.
Good afternoon. My name is Stephanie George, and I'm from the National Institute of Arthritis, Musculoskeletal, and Skin Diseases. I'm pleased to welcome you back to the final session of our BSSR Festival. The COVID-19 pandemic has brought out unprecedented levels of change in the way we live, work, play, interact, and behave. This last series of speakers today have used the pandemic as a catalyst for creativity in the BSSR space, and I think you'll find the innovation in their research inspiring. I'm pleased to welcome our first speaker, Dr. Shlomit Radam Isaac from the University of California, Irvine. She'll be presenting on face covering, physical distancing, and physical activity behaviors in schools, quantifying the fidelity of mitigation strategies in the midst of the COVID-19 pandemic.
So good afternoon, everyone, and thank you, Dr. George, and the organizing committee for the invitation to participate in the 2021 BSSR Festival. I'm representing today the Systematic Observation of COVID-19 Mitigation SOCOM research group that was formed during the summer of 2020 following an invitation from the director of the Institute for Clinical and Translational Science in UC Irvine, Dr. Dan Cooper, who is also the Orange County Healthy School Restart Study inaugural leader. Our group was basically formed to develop an instrument that can quantify the fidelity of COVID-19 mitigation strategies in a school setting. So on behalf of our SOCOM research group, first I'd like to thank again the organizing committee for the opportunity to present SOCOM for the first time in this event. I'm going to start with a brief background on COVID-19 in kids, discuss key gaps in knowledge, what we needed to know to keep the schools safe, present SOCOM, the systematic observation of COVID-19 mitigation instrument, share with you a little bit about the results, what we found, and discuss next steps. As of November 2021, nearly 6.6 million children have tested positive for COVID-19 since the onset of the pandemic. And over the past 8 weeks only, over 1.1 million additional cases were added. So we all know that children are not miniature adults. And yes, this is true in this pandemic as well. Children are less likely than adults to develop severe COVID-19 symptoms. You can see them over here at the bottom of the figure. However, we have to keep in mind that some otherwise healthy children can become severely ill, and in some rare cases, even develop MIS-C, multi-system inflammatory syndrome, which is a rare pediatric and very serious inflammatory response. The other thing that we have to keep in mind is that asymptomatic infected children, and there are many of those, can transmit the disease as well. In the spring of 2020, when pretty much at the time that COVID-19 was declared as a pandemic, the schools were among the first operations to close to prevent community spread. And then a few months later, in the fall of 2020, when the children and the adolescents resumed school, they did it with varying degrees of in-person classes. So the CDC provided mitigation guidelines, and at that time, initial strategies including physical distancing, mask wearing, and hand hygiene. There is so much data that show that implementing those mitigation strategies can keep the school safe and prevent the spread of the disease. And this is one report from the CDC from a couple of months ago that present data on pediatric COVID-19 cases in 520 counties with and without school mask requirement. The data was collected 3 weeks before start of school and during the first 2 weeks of school. So the blue bars over here are the counties without school mask requirement. And we can see that the blue bars has a much greater mean change in daily of COVID-19 cases compared to the counties without school mask requirement. So this basically can indicate lapses, and that lapses in universal masking may contribute to the COVID-19 outbreaks in the school setting. So this is my report, but there is lots of data to highlight how important it is to implement prevention strategies for safe in-person learning. However, when we are thinking about those mitigation protocols, some of them, like physical distancing or mask wearing, those are unnatural behaviors for children. So the big question is, how do we quantify or how well mitigation protocols can be implemented in the schools? And this is pretty much the reason why we worked so hard on developing a SOCOM, because this instrument should give us the ability to quantify the mitigation strategies in the school. As one of the first steps in developing this instrument, we had to evaluate the challenges of working in the schools. And one of the challenges that is very high on the list, or we can say that maybe the highest on the list, is the privacy issue. The school takes very seriously the privacy issue. They protect the privacy of the student, and this is actually very, very good. However, identification of individual students is absolutely not allowed, and we had or we could not use any cell phones or GPSs or videos to capture data in the schools. So taking into consideration the privacy issue and other issues as well that we don't have time to discuss today, our small group agreed that taking the approach of social science methodology and using direct observation method might be the right way to go in developing this tool. So for SOCOM, the systematic observation of COVID-19 mitigation, SOCOM adapted from two already existing platforms or instruments, the SOPLAY and SOPARK. Both of them are instruments that were designed to capture physical activity in the schools and physical activity in playgrounds and parks. Those platforms are already validated platforms, and both SOPLAY and SOPARK, and now also SOCOM, are based on momentary time sampling techniques in which systematic and periodic scans of individuals are done by trained observers. The SOCOM is focused on physical distancing and face covering. However, we kept the physical activity features in this instrument because we think that this is very, very important to evaluate in the schools. Dr. Kai Zhang, the Director Center for Biomedical Informatics in the ICTS in UC Irvine, designed an electronic data capture system that is optimized for mobile devices and can obtain weather in real time. All the data that we collected were stored in secure environment in UC Irvine. For our observers participated in a 3 to 4 hour training session to get certified. There is a need for a certification. We used videos and pictures to practice the assessments, how to assess face covering, physical distancing, and physical activity, of course. We had one practice run in the field, and we sent the local SOCOM team to the different schools to map target areas where we would like to capture the data. For this project that I'm presenting today, we focused on target areas of the classroom, the active races, the PE class, and the communal dining. We assigned 2 observers per site, and the observers were supposed to work simultaneously, however, independently, to capture the data. And by looking at the interrelated reliability analysis of 166 scans, we see that the agreement between the observers was very high for all the activity types, for the face covering, the physical distancing, and for the physical activity type. We implemented the instrument in 4 schools in Orange County. School A and School B are schools in Santa Ana with a population of predominantly Hispanic family with a low socioeconomic background. School C is a school that cares for students with special needs, and we are going to talk a little bit about it later. And School D is a private school with a population predominantly middle and upper middle class families. So in the next few slides, I'm going to share with you a little bit what we've found. The first slide summarizes the mean SOCOM values of the compliance to both physical distancing, that at that time it was the fall of 2020, was equal or greater to 6 feet, and face covering in the 4 different target areas that we set up: the classroom, the communal dining, recess, and PE class. And we can see that the classroom physical activity distancing over here was significantly higher. The compliance was significantly higher compared to the other target areas, while the face covering was lowest in the communal dining, which makes perfect sense. So basically what we would like to show over here is that SOCOM can give us information and inform us about the adherence to different either physical distancing or face covering in different target areas of the school. And we set up those target areas, but technically any school can set up whatever area that they wish to learn about. So if we look at the recess over here, we can see that the compliance was relatively low, about 50%. Maybe this is something that we should expect, but if this is something that is not expected, the school can immediately respond to that and adjust, improve the compliance. The next slide, this slide is presenting data of the individual schools, schools A, B, C, and D, data that collected in the classroom for both physical distancing and face covering. And overall, you can see that the compliance was very, very high in all schools. However, in School C, that is a school with the children with special needs, the compliance was a little bit lower. So this SOCOM data was analyzed with the Healthy School Restart study that I mentioned at the very beginning. And what they found that there is no correlation between the in-classroom data, compliance to physical distancing and face covering, which was very high, and the SARS-CoV-2 positivity that they actually sampled on a subgroup of participants from those schools that we were working with. And this actually follows other studies that have shown that when multiple prevention strategies are in place, there is lower transmission in the schools compared to the community setting. The last slide results, I'd like to talk a little bit about physical activity. So we used SOCOM to capture also data on physical activity. We did it during the standard PE classes and the special need PE classes. And what we can see is that the percent of the students that were active during the standard PE classes was about 70%, which is much higher compared to the less than 20% in the class with a special needs. And there is a reason, very good reason why this is what we see. Basically, in the school with the children with the special needs, at that time, again, it was the fall of 2020, the PE classes was done in the classroom, practically by their desk. There was really little space for them to move around. So it's not surprising that this is what we see. So SOCOM could capture what the level of active or not active students in the classroom. And I hope that if a school personnel in this specific school get the results, they can respond and adjust and make sure how to modify and increase the activity during those PE classes. So to summarize, SOCOM is inexpensive research tool that can be implemented by schools to determine mitigation strategy adherence and to assess protocols that allow students return to school safely and slow the spread of COVID-19. Currently, there are a couple of ongoing SOCOM studies. They are both in early stages of data collection, both in Orange and Los Angeles counties and in Flagstaff, Arizona. And our vision, and we wish to be able to do it in the future, to have a user-friendly SOCOM for school personnel to use, that they will be able to monitor and adjust mitigation protocols when needed. So I'd like to end with a note that we got from a school principal from one of the schools that we were working with. And this is what she writes. The UCI study meant so much to our school community. Our learners, parents, and staff felt like we had our own healthcare team, all at a time of great fear and anxiety about COVID-19. We've asked the leader of Santa Ana Unified School District that we want to be part of future studies as well. So this is a great opportunity to thank all our community partners, to thank the Pediatric Exercise and Genomics Research Center study team that collected the data in the schools, and to acknowledge our SOCOM research group, Dr. Ricky Campaign and Nanette Gigi Lopez from the Northern Arizona University Department of Health, Thomas McKinsey from San Diego State University, who technically originated the SO Play and SO Park instruments, Dr. Guy Zhang and Dan Cooper from UCI. So thank you.
Thank you so much, Shlomit, for this excellent talk. So we have a question in the box. Can you elaborate with the same constraints that all schools have in fall 2020, why PA activity for students in the special ed group was so low compared to the others? Thank you.
So the main reason, so those are two challenges, and then go to so additional challenges at that time, that and it's true for now as well, that non-school personnel are not allowed to be on campus ground. This is one thing. The other thing, as I mentioned, was the privacy issue. Another issue was that schools were very strict and wanted to keep their school schedule as they should. All this together, and additional changes for different schools, because each school has different policies and different way that they are working, made it a tool that we had to think how to create it, that it will be really simple to use, that people from the school staff themselves can capture the data, no need for outside observers to get into the schools, no identification. So, and this is direct observation, we are just counting heads, absolutely not doing more than that. By the way, we have and we do capture data separately for boys, separately for girls, and for school staff as well. So this can get more granular if you want to. So this is one thing. The other thing that is very dear to our heart from the Pediatric Exercise and Genomics Research Center is the levels of physical activity in this specific school. So this specific school had limitation. I'm happy to say that they moved to another location and now they have a gym since last year. At that time, they were very limited in the way that they can deliver physical activity. I brought this slide just to show you the power of the tool, that it can capture what is actually going on in the field. So it could inform us, this class, maybe they call it physical activity, but there is very little physical activity during this time. So now they are doing much better.
Great, thank you. I have a question. I'm wondering, the pandemic obviously brought about this kind of change that inspired your project. How were you able in such a short time frame to be able to think about the adaptation of not just one, but multiple tools into the tool that you developed that could be used in future BSSR research?
So basically, we were lucky, and I think that the most important point was to identify the SoPlay and SoPark. Once we identified, they were really the perfect instruments to be adapted to SOCOM. So we had lots of discussions, lots of Zooms. Everybody were sitting wherever they were sitting and exploring and brainstorming how and what would be the best way to go, including accelerometers, yes, no, any sensor that we can implement. And those are, again, additional challenges to this study. Accelerometers, just as a side note, they can detect physical activity, but they don't have the feature of physical distancing. So this was not a good option for this mitigation strategy. So once we had SoPlay and SoPark, they are so easy to use. And from there, it was relatively easy to bring into this group Dr. Kai Zhang that actually created the app for the cell phone.
Thanks, and I'll open up. Oh, we have another one here. Did you capture prompts by staff and teachers to remind students to comply with the guidelines?
So that's a very good question, and thank you. We tried to do it the other way around. We wanted to be invisible. We didn't want people to see us over there because that's not the idea of this tool. Now, we were strangers to the school. I think that once the school are going to use it, if they are going to use it with their own staff, so there is going to be less visibility. So in the first couple of visits in the school that basically did not get into the data analysis, people were looking at us, students and teachers, they were asking, what are we doing over there? We always, the observers, were trying to stay very far away. And that's the beauty of this tool, that you don't need to get closer, but when you screen in the classroom, you go by the door and everybody can see you. After a couple of times, nobody asked questions. They all knew that we are over there from UCI. They even didn't care what we are doing over there. And we didn't want to say anything.
Thank you. And I'll open up to the panel. If anyone else has any questions, feel free to unmute, turn your video on and ask that question.
Stephanie, this is Bill. I'll jump in. Shlomit, that was just excellent research. It's really nice to see direct observational work. My master's thesis many years ago was watching little kids in recess and look at their social interaction. So it's nice to see direct observation still being used on a regular basis. I did have a question for you about the expansion of this into other states. You know, California's been quite good about its communication around face mask wearing and physical distancing, and fairly consistent about its communication about the value of that in school systems. That's not necessarily been the case so much in other states. Is there any effort for others to use this and do some comparison among states?
So I'm not sure that I can answer this question. I think that first, regarding the guidelines, we have nothing to do with the guidelines. And this is a great point, because technically the guidelines keep changing all the time, even over here in California. So SOCOM now, if there was a value to assess physical distancing outdoor. Now there are no guidelines for that, so we should not use it for that. It might come back. This is just a tool that we can adjust for any mitigation guidelines that might come up. And if somebody would like to use it, and it's technically, I think, more work in the school leadership level, that they should be aware that there is a tool, and if they would like to make sure and get and be informed on what's going on, and maybe they can do something if there is something that can be done and correct for a low compliance, this is where we should work with. But right now this tool is technically not even at the phase that we can offer it to everybody. We did the training for our observers and the other studies over in Arizona by Zoom. So there is not yet a video training or any resources that they can train themselves without having the need to have us involved, and this is time consuming. This for sure need a certification because we would like to get quality data, and there is a need to make sure that people knows how to do it. It's not that it cannot be done, it can easily be done. It just need to get to the next level to do that. So I'm not sure that I answered.
No, you did. Thank you very much.
Thank you so much. All right, thank you very much, Shlomit. We're going to move on to our next talk today. And this talk is by Dr. Genevieve Duncan. Genevieve is actually a little bit under the weather today, and so we are going to play a video of her talk, and then she'll be live with us for the Q&A portion. So we'll save a little bit of her voice. Dr. Duncan hails from the University of Southern California. So with that, I will leave you with the presentation.
Good afternoon. It's a pleasure to be here and to take part in the NIH OBSSR Research Festival. Today, I'm going to share our recent research on the impact of the COVID-19 pandemic on children's physical activity and sedentary behavior. The COVID-19 pandemic has impacted almost every aspect of our lives, from how we work to how we learn to how we purchase food. Social distancing requirements have led to large-scale social and behavioral changes that may last well beyond the initial months of the pandemic. Some have even discussed the need to adopt a new normal, as COVID-19 may lead to permanent changes in how we live our lives. Physical activity behaviors were especially hard hit during the early days of the pandemic, with the closure of schools, gyms and fitness centers, parks and playgrounds, trails, and the cancellation of sports and activity classes. Children were in a difficult position because with remote learning, many critical opportunities for physical activity had been lost, including walking and biking to school, recess, and physical education, and after-school programs. Although outdoor and indoor activity spaces have reopened for the most part now, children in many states are still required to wear masks and practice social distancing during school and organized sports. Children's daily routines were drastically impacted by the distance learning that took place during the first year and a half of the pandemic. Instead of face-to-face physical interactions with their teachers and their peers, they were typically spending 3 hours or more per day in synchronous learning through a screen, and additional screen time was spent in asynchronous learning. This makes for a lot of time spent sitting each day, with limited space to get up and move around, especially among children living in small homes or apartments. Despite these challenges, though, some families and children did find ways to maintain physical activity during the early days of the pandemic by either exercising outdoors or virtually. However, both of these opportunities may be severely limited among lower income and socially disadvantaged families who may not have outdoor space at home or who live in unsafe neighborhoods with higher traffic or crime, or who cannot afford online activity classes and lessons. These challenging conditions have led physical activity researchers to ask how the COVID-19 pandemic has affected physical activity in children, and perhaps more importantly, will children maintain new behavior patterns that they adopted during the pandemic, or will they revert to old patterns that happened before the pandemic if and when the conditions return to normal? The impact of the COVID-19 on children's physical activity is important in public health because pre-pandemic levels of physical activity in this age group were already quite low. And from a developmental perspective, as you can see here, mid-childhood to early adolescence is a particularly important time for maintaining physical activity because it's a period when we tend to see these rapid declines in activity levels that do then track into adulthood. We also see large sex differences in children's physical activity, with boys being significantly more active than girls at all ages. And a great concern amongst physical activity researchers and practitioners is that the pandemic could lead to permanently altered physical activity trajectories amongst children. We know that individuals who experience lapses in regular physical activity routines are much more vulnerable to never going back to their original levels of activity because new inactive habits form. So the pandemic could lead to losses in physical activity levels in children, as you see here, these altered trajectories that may never be regained as they move into adolescence and adulthood. Today, I'm going to share results from our study, which was published in BMC Public Health last year. In order to understand the impact of the COVID-19 pandemic on children's physical activity, in April 2020, we initiated a study at the USC Keck School of Medicine in collaboration with partners at Colorado State University. And we enrolled parents of children who were ages 5 to 13 years old. And all of our questionnaires were parent reported, and the families lived in the US, and the parent needed to speak English and have at least 50% custody of the child. And we recruited families through social media and listservs. Here's the study design. You can see here that we collected an online baseline survey, and this was in the early months of the pandemic, April and May 2020, and this was during the most restrictive period of time, during the shelter-in-place or stay-at-home order in many states. And then 6 months later, we collected an online follow-up survey in December 2020, and then after another 6 months, in June and July of 2021, we collected another follow-up survey. And in general, these surveys assessed COVID-19 history and symptoms, and we asked about the family's participation in social distancing, and about children's past and current physical activity and sitting. We asked about locations of physical activity and the use of remote streaming services and parks and dog walking for physical activity. And we also asked about a number of features of the home and neighborhood environment and sleep patterns and demographics. And here's a description of our sample. There were 211 children represented on the baseline survey, and they were ages 5 to 13 with the mean age of about 8 3/4. About half were female and 13% Hispanic. And you can see here the racial distribution. About 96%, almost all of the parents reporting were mothers, and most of them were married, and over half worked full-time. You can see in terms of the annual household distribution that quite a large number were of moderate to higher income. We see about 68% reported earning an annual household income of over $125,000. Children in the sample resided in 35 different states and the District of Columbia, with almost a third of them living in Southern California, where the study was initiated. So during the early COVID-19 period, so this is in the April and May of 2020, we asked parents to report specific types of physical activity that their children had performed on the previous day. And in general, you can see here that we found that free play and going for a walk were the most commonly reported types of activities, with about 90% and 50% of children engaging in these types of activities respectively. However, we did see that there were some striking sex differences and age differences in the types of activity children performed during those early months of the pandemic. We saw that boys were more likely to engage in sports practices and girls in activity classes. And then we also saw some age differences, with free play being more common amongst the younger age group, as well as biking. We also asked parents to report the specific types of sedentary behaviors that their children had performed on the previous day during this early COVID-19 period. And we saw that TV and video games, as well as schoolwork, were the most commonly reported in this case, but we did see sex and age differences as well. We saw that video games were more common amongst males, and the females, the internet and emailing. And we did see age differences too, with the older children more likely to engage in all the different types of sedentary behaviors. So overall, during the early COVID-19 period, we did see that there was about 90 minutes of school-related sitting and about 6 hours of leisure-related sitting on any given day. And this led to about 8 hours of total sitting at a day level. And we did see that these levels of sedentary behavior were higher in girls and older children. So children were really spending a lot of time sitting in these first few months of the pandemic. We also then looked at the locations of children's physical activity and saw that they changed from the pre-COVID-19 period, which was February of 2020, to the early COVID-19 period from April to May of the same year. So we saw that during the early COVID-19 period, children were more likely to do physical activity at home indoors and in their neighborhood, whereas physical activity taking place at a park drastically declined. Therefore, our hypotheses about how restrictive COVID-19 policies may have led to lack of access to park space for physical activity and the displacement of school-based physical activity and team sports to indoor settings during the pandemic were confirmed. Finally, we asked about children's use of streaming and remote services for physical activity during this early COVID-19 period. And somewhat surprisingly, we saw that a substantial portion of children were taking this approach. And the data was suggesting that in this case that over the past 7 days in early COVID-19 period, about a third of children did participate in some type of online activity class, and 10% participated in online team sport. But these rates of participation in remote streaming services for physical activity were 5 times more common in older children, the 9 to 13-year-old group. So these data suggest that in the future, children may be receptive to these type of technologies as replacement for in-person forms of organized physical activity. And that could be useful because these organized in-person activities can be time and resource consuming for families in terms of transportation and other costs. However, though, whether the use of remote and streaming services to promote children's physical activity is an effective way to teach skills or can be offered equitably across diverse socioeconomic groups and then continue after the pandemic need to be further investigated. Although we didn't have pre-COVID physical activity data on these children, we did ask parents to report how physically their child was in the pre-COVID period compared to the early COVID-19 period. So this is their perceived change in activity from February 2020 to April, May 2020. And we found in general that parents reported their children to be less physically active and more sedentary in this early COVID period. But there were age differences. Almost twice as many parents of tweens, this 9 to 13 group, reported that their children were exercising much less than parents of younger children, 5 to 8 years old. And about 36% of parents of younger children, compared to 47% of parents of older children, reported that their kids were much more sedentary. However, I want to point out that the pandemic didn't seem to have a universally negative effect on the activity levels of all children. We saw that about 15% of younger children reported their children did much more physical activity during the early COVID-19 period than before COVID. And we saw that about 8% of parents said their children were doing much less sitting, but this was just in younger children. So we're in the process of analyzing our follow-up data that was collected in June and July of 2021. So this is 16 months after the pandemic started. And so far we found that younger children seem to have recovered reasonably well in their physical activity and sedentary behavior levels. So in this case, parents were perceiving that the majority of younger children were doing about the same amount of activity in June and July 2021 as before the pandemic. And we saw about the same in terms of sedentary behavior. But however, we saw older children still remain much less physically active. In this case, 32% were doing much less physical activity in the June, July 2021 as compared to February 2020. And we also saw that 40% of older children were still doing much more sedentary behavior 16 months into the pandemic. So in terms of the important take-home messages, what can we learn from these data? We saw that during the first 2 months of the pandemic, physical activity did decrease and sedentary behavior increased. And these changes were much larger in older children and girls. We saw free play and unstructured physical activity were quite common in the early COVID period. Inside the home and in the immediate neighborhood were key locations, and we saw that remote and streaming services could possibly be viable options, but they may be cost prohibitive. And then after over a year into the pandemic, in June and July 2021, we saw younger children's activity levels, for the most part, had recovered, and their sedentary behavior had recovered to the pre-pandemic levels. But older children, we did see potentially lasting impacts with much more sedentary behavior and less physical activity than pre-COVID-19. So what these data suggest is that we need to focus on developing ways to promote children's physical activity and reducing sedentary behavior during these uncertain times, and that's important both now and beyond the COVID-19 pandemic. With rapid changes to our climate, it's possible that we may never go back to an old normal again, and instead face this new normal, which could involve more pandemics or wildfires, weather events, or climatic changes. And therefore, it's even more important that we understand how to help children maintain physical activity and other healthy lifestyle habits during these types of unexpected disruptions. I just want to end with acknowledging my collaborators and my research team on the study listed here and our funding. And if you have further questions, you can email me here below and check out our Reach Lab website at USC. Thank you.
Thank you so much. Terrific presentation, Genevieve. Our first comment is here. Terrific presentation, Genevieve. Thank you for participating today. I'm concerned that changes in diet and physical activity during the pandemic may have accelerated increases in obesity rates among many age groups, which will have long-lasting effects even after we get more control over the COVID-19 spread. Do you have a sense of whether that's a legitimate concern? And do your data tell us about the potential magnitude of long-term effects?
Yeah, that's a great question. And so we don't have data on obesity. We didn't measure height and weight in our sample, but there are data coming out. Certainly, recent data that are showing that adiposity increased in cases, and so we'll continue to look and see what happens with these trends. But there's certainly preliminary evidence that's suggesting this, and it's quite similar to what we typically see often during the summer months. So in children, often there is extra weight gain that goes on during unstructured periods of time when they're not in school in the summer, and so I think that definitely is a concern, and there is some preliminary evidence that is suggesting that. So we'll have to keep close tabs on it.
Thank you. Could you comment on the profound effect that SES will have on physical activity in children?
Yeah, well, obviously, during the pandemic and beyond, the disparities, socioeconomic, racial, ethnic disparities have become pretty evident. So I think this is something that we've discovered throughout the pandemic, that it's really shown a spotlight on cracks and inequalities that existed already, and they're just much more evident now. And so certainly that's one of the reasons why going back to an old normal, it maybe isn't something we should even strive for, that this is an eye-opening experience for us. And so certainly the data that we have, and I shared today, and others' data suggests that when thinking about children's activity and access to facilities and locations and remote streaming, these are features that may not be equitable across all groups, parks, and safe neighborhoods to walk in. So once schools no longer became an option for children, and they lost their PE and they lost their opportunities to after-school programs, it really relied on a home environment and the local neighborhoods, and certainly that there's a lot of disparities to access to places to be active in those locations.
Was there a relationship in your work between parental physical activity and that of their children?
We did not look at that in this study, but we have a number of other studies that have looked at that and have found quite strong associations between children's activity and their parents' activity. Now, whether that's due to role modeling, whether that's due to them doing joint physical activity versus separate physical activity, is something that we've looked into in others as well. And so Certainly what we're seeing is that promoting activity at the family level is pretty critical. And that if kids are being active, parents should join in and vice versa. Those are they're pretty much lost opportunities otherwise. And so, yeah, certainly I think that's an important option.
COVID-19 severity was influenced by obesity. Do you think that fitness per se enhances resilience to infections like COVID?
Well, we have seen some data on that. Certainly that respiratory health, respiratory fitness, having a stronger baseline levels of that going into an infection, a respiratory infection like COVID, can help and be protective and hope. In some cases, the data suggests that they lessen the severity of the disease, and so that's an important public health message. And there have been some pretty good papers that have been put out by Jim Salas and others that have called for increased awareness of physical activity and physical fitness as a protective factor against COVID-19. I'm not sure it's picked up as much in the general media, this message. And so I think it's something that we can do a better job at in the public health community and behavioral science community about highlighting that research as a protective factor for COVID-19 disease.
I have a question myself, given the entrenched patterns that your data is showing, especially for those 9 to 13-year-olds, what kinds of innovations are needed in behavioral interventions for groups of 9 to 13-year-olds and other age groups as well to try to break out of that pattern?
That's going to be hard. I do worry about that group. The younger group, at least some of our initial evidence suggests that they are bouncing back. And that's really positive. This 9 to 13, this tween group, early teenage group, I do worry that they were already on this. Their developmental period is already within this downward trajectory of activity levels and increased sedentary behavior, and we just might have exacerbated it with some of the restrictions that happened during the pandemic. So, one thing that could be possible is promoting more school-based activity in the middle school. I think that's something that often is lost, especially in recess periods are cut back or eliminated in middle school and high school. So thinking about that, obviously keep maintaining PE in the school at those later grades is going to be pretty critical. So I think that's something that might be the lower hanging fruit, and I'm thinking about how to build in more of that. For groups that have access to it, or we did see that there's a lot of interest in these online activity classes and lessons, and so either making that freely available, more accessible to all groups and SES groups, may capitalize on just an underlying affinity that these groups have, these age groups, for online technology, and so that could also be a viable option.
Thank you. I want to open it up to the panel for any questions. Feel free to unmute and turn your video on to ask that question. Okay, I think we're complete. You had a series of these here. We're really grateful for your presentation. Thank you so much, Genevieve.
Yeah, thanks everyone for bearing with the recording.
Of course, totally fine. All right, our last talk today is by Dr. Hillard Kaplan of Chapman University. And the title of this talk is Collective Action, Behavioral Models of Transmission and COVID-19 Outcomes in 2 Native South American Populations.
We'd like to express our gratitude to the festival organizers and the NIH for this opportunity to present our findings of COVID-19 outcomes in 2 Native South American populations, the Tsimane and Moseten, living in the Bolivian Amazon. We've been conducting collaborative community-based research studying chronic disease with a focus on Alzheimer's and related dementias for 19 years with the Tsimane and 6 years with the Moseten. COVID-19 provoked a health emergency with both ethical and scientific dimensions. There was an ethical obligation to help mitigate an extreme threat to a vulnerable population, and a scientific need to monitor infection and outcomes for interpreting longitudinal data on cognitive aging with an intervening pandemic. We were awarded supplemental funding by the NIA with a three-pronged approach. One was to help support collaborative education and collective decision-making in the communities. Two, to conduct ethnographically informed epidemiological modeling of disease transmission, and to help mitigate mortality risk and monitor disease outcomes. The Tsimane are a population of approximately 16,000 individuals living in over 100 small villages, engaging in subsistence farming, hunting, fishing, gathering, but with increasing market involvement. The Moseten are a population of about 3,500 living in 10 villages, but they're more integrated into the market economy, engaging in commercial farming and purchasing most of their food. Especially the Tsimane, but the Moseten as well, engage in high lifelong physical activity. This figure compares steps per day of Tsimane men and women with the US NHANES sample, showing that they are about twice as physically active through life as Americans. But they have a very high burden of infection, including intestinal parasites and respiratory diseases. This figure plots eosinophils over the life course, comparing the Tsimane to the USN NHANES sample as well. Eosinophils are a response to parasitic infection and shows their lifelong burden of disease. However, they have a very low prevalence of hypertension, obesity, diabetes, and cardiovascular disease related to their lifestyle. This figure compares coronary atherosclerosis in the US MESA sample with the Tsimane, showing that clinically relevant atherosclerosis increases radically with age in the US, becoming about 7 times more likely in the US than in Tsimane. There are some common vulnerabilities and strengths among indigenous, aboriginal, and tribal populations with respect to diseases like COVID. There are vulnerabilities. They live in regions with poor health infrastructure, poverty, and discrimination, and they suffer from comorbidities of various types. But they do have some sources of resilience, the ability to produce subsistence foods. Many have government recognized tribal sovereignty, cultural traditions of collective decision-making, and a lower population density and ability to disperse. The first prong of collaborative education and collective decision-making occurred during March to June of 2020, before the disease actually hit the populations. So we coordinated with the local tribal authorities to engage in community level information and collective decision-making, translating CDC educational materials into Tsimane and conducting over 50 community meetings. The result of these meetings was a fairly universal collective decision to self-isolate, with people signing formal meeting acts. We helped distribute supplies to the communities, such as salt and soap, to help them self-isolate. We purchased PPE and portable oxygen concentrators for moderate cases. This approach was published in Lancet in May of 2020. Next, I'll show you a short clip of the Vice President of the Tsimane Leadership Council leading one of these community meetings. And here are some photos of other meetings, distribution of some supplies, and a community putting up a barrier to keep people out. To model what would likely happen with SARS-CoV-2 infection in the Tsimane, we used data that we had collected previously, the census data, the location of households, time allocation of community visitations going from one community to the other, frequency, and importantly, visits to town where the most likely would be sources of infection to be brought back to communities, and social network data. What our model showed was that without significant intervention, about 75% of the population would be infected within a matter of 3 months. Then we also looked at what would be the potential effects of different interventions, the reduction of travel to town, reducing inter-village travel, combining those. And what you could see is that the cumulative number of people infected is almost the same, unless you really double down on both lower travel to town and within communities, but still you only get to 50% infected. And with masks and social distancing, and restricted travel would be the only way to really get there with much lower rates of transmission. So this is what actually happened. Right at the end of June, beginning of July, disease cases propped up all through the Tsimane territory. Here's the main river system that the Tsimane are living in, their villages. And the main reason why there was this infection into the villages so quickly was that people could no longer afford to self-isolate. They felt that they needed to bring their products to town and sell them. And so very quickly, the disease spread through the Tsimane territory in about a 2-month period. So infection rates were very high. Using ELISA antibodies, we estimate that about 73% of the adult population was infected. The actual infection prevalence matched the model predictions almost exactly, but the infection spread even more quickly than predicted, likely because their dependence on trade in town had increased since the data were collected. And the infection basically hit all ages, sexes, and no risk factors really affected who got sick. There was a slightly higher prevalence of infection among the Tsimane than the Moseten. We also looked at neutralizing antibodies by age, population, and sex. And interestingly, 83% of the infected individuals produced neutralizing antibodies, compared to only 33% among German COVID survivors. This very vigorous immune response was found among all ages and both sexes. Slightly higher responsiveness among the Moseten than the Tsimane, but almost identical. With respect to symptoms, about 50% had 6 or more symptoms. 60% reported loss of smell and taste, some 50% difficulty breathing. There were very, very few asymptomatic individuals. And interestingly, symptoms were associated with the presence of neutralizing antibodies. More symptoms, more neutralizing antibodies. About 19% reported being sick for more than 3 weeks, but most people tried to work even when sick, going out to their fields, and very few being bedridden. And this is associated with their idea that you have to work to eat. So in summary, looking at the ELISA spike ratio, seroneutralization titers, and severity, we found that the antibody responses increased with age and with disease severity in terms of days sick, days in bed, and not working normally. Antibody responses were lower in males, but they reported more days sick in bed and not working normally. And systolic blood pressure was the main risk factor that was associated with disease severity, both with neutralizing antibodies and days sick and in bed. There was very, very low case fatality in both groups. We observed 1 Tsimane death and 2 MOSA 10 deaths during this period. To examine this case fatality rate in holding constant age, we used data from New York City from March to June of 2020 and the estimated case fatality rates by age there. And using these age-adjusted case fatality rates, we would have expected 45 deaths in the Tsimane if they had died at the same rates as New Yorkers, and 11 deaths in the MOSA 10, sort of suggesting that New York residents were 45 times more likely to die of COVID than Tsimane, and 5 times more likely than MOSA 10. Looking at this in a more comparative perspective, COVID mortality among those over age 45 was about somewhere around 0.1% among the Tsimane and 0.5% among the MOSA 10. This is significantly lower than other indigenous groups in the Ecuadorian Amazon and Brazilian Amazon, with mortality rates across all ages of about 1% to 1.5%, and much lower than case fatality rates reported by country, where low is about 2%. So we're an order of magnitude lower. So there is a Tsimane MOSA 10 paradox to be explained. They had extremely high rates of viral transmission, most individuals having multiple symptoms, high rates of spike and neutralizing antibodies, indicating both significant morbidity and immune responsiveness, but very extremely low mortality. What might be some potential factors that might help explain the paradox? Well, in terms of risk factors, the communal lifestyle with food sharing and lots of household visitation likely increased the rate at which the infection spread through villages. But the low obesity, diabetes, and hypertension prevalences probably prevented disease severity and mortality. And there are also some potential protective factors to consider. Their high pathogen burden may have been associated with previous experience with other coronaviruses, may have modulated their immune response. They themselves think that continued activity versus staying in bed made a difference to them being able to recover from the disease. Another possibility has to do with their helminthic parasitic infection in eosinophils. Previous to the pandemic, we had done some studies of stimulating blood samples with H1N1 antigens and compared those with higher eosinophil counts to those with normal, and found that their cytokine responsiveness, especially Th1 cytokines, was reduced in the individuals with elevated eosinophils, suggesting that this may be related to the lack of a cytokine storm. There's also data from Ethiopia suggesting that there may be an impact of parasites on lower mortality and disease severity. There may also be some yet to be discovered protective genes. So here are some concluding thoughts. Indigenous peoples are particularly susceptible to a high prevalence of infection in pandemics due to poverty, high social connectedness, and dependence on market exchange. Individual economic and social decisions undermine collective decisions to self-isolate, allowing pandemic infections to evade and spread quickly through social networks. Perfectly timed isolation is very difficult to achieve. Worldwide, the control of individual behavior has been the biggest challenge for pandemic containment, with only strict enforcement being associated with success. Vaccine fear and COVID misinformation have penetrated even the most remote groups, including both the Tsimane and Mosa-10. Case fatality rates and immune responses differ markedly among populations, and understanding the causes of that variability is an important research priority. And with that, I'd like to thank the National Institute of Aging, program officers, and all my collaborators, as well as the Tsimane people.
Thank you so much, Hillard. And the floor is open for questions. We've got a first one here. Would you speculate that the resilience among the tsunami, e.g. increased physical activity and reduced obesity, could be a manifestation of the hygiene hypothesis used to explain the reduced asthma in children exposed to helminths earlier in life?
That's interesting. I think that the way I'm thinking about this is that the impacts of the helminths early in life are actually programming the immune system and changing the relative emphases of the Th1 immune responses with those that are more of the other antibodies, Th2, that are towards the parasites, and therefore leading to a sort of less hyper-intensive immune response to antigens like asthma, and that the increased physical activity and decreased obesity is just another reason why together we had a lower severity of disease and mortality rate. So our best guess is that it's multiple factors together that are at play here.
Thank you. And I'd like to open it up to any panelists who may want to ask a question. Feel free to unmute and ask that question. While we're waiting, I can start us off with one. You showed some data about continued activity, so physical activity patterns in just the way these groups live and as part of their normal life. What kinds of measures have you used to look at those activity patterns in any of the research that you've done with these communities?
We started first with waist-based accelerometers as well as wrist-based. We also use the same kinds of methods that were described for the schools in the previous talk, in which we do scan sampling of individuals and what they're doing at random points in time. And both sources of data show the very big differences in physical activity. So for example, 17,000 steps per day is what we recorded with waist accelerometers as an average for adults.
Thank you, that's impressive. And now there are two other questions that were going to be my second question. So many are thinking alike here. What are the attitudes of the tsunami towards vaccination? And what's the vaccination status in these two groups? I might add to that also, while you're tackling vaccination status and like attitudes, any kind of hesitancy, can you also talk about other mitigation behaviors that were covered too, like mask wearing?
Okay, so there is tremendous vaccine hesitancy. In fact, it's so great right now. If you even mention doing vaccines, people run away and won't let you do regular primary care. And the idea that there is a chip in vaccines that will be activated some years later to kill off the Tsimane population has penetrated deeply into the population. And I held a virtual meeting. I brought in members, the leaders of all these different villages to discuss the vaccines. And basically, the idea that we might be trying to push the vaccines really exploded in our faces, to be honest with you. And we had to back off completely from any attempts to do vaccines. And in terms of treatments, the Tsimane have a whole list of home-based remedies that they used, from tree saps and leaves of different types to combat COVID, and they went full scale into traditional medicine. And they believe very strongly that their traditional medicine played a role in their ability to fight off mortality.
Thank you. And are there any additional questions from the panel? Would anyone like to ask another question? Has there been any effort on the part of universities to determine the potential efficacy of these remedies that you mentioned for treatments for COVID?
Actually, I haven't seen anything in that direction. And I think it would be very interesting to take that on and to look. What we have done is we conducted a post facto interview with people while we were collecting the blood samples for the antibodies, and what did you do to treat yourself? So we have the list for every individual of what they did, and we can even try to look at the relationship between their reported disease severity, their antibodies, and the different treatments that they utilized. But we also then have the list that could be used for further studies.
Thank you. Any other questions? And Dr. Kaplan, I'm sure you've seen that OBSSR headed up an effort this past year on vaccine hesitancy, specifically about COVID-19 vaccine communication. So I'll have someone from our team put that down in the box at the bottom. So anyone listening wondering about COVID-19 vaccine communication strategies, which of course are evolving day by day, given challenges with different groups and no one being just like the other. But it's a great report to go to look at for some strategies as well. And with that, yep. And with that, hearing all these physical activity talks reminds me of one of my family's favorite sayings at the very end of a race or kayak ride or walk is the final finale. So here is Bill Riley for our final finale of the OBSSR's annual research festival.
Stephanie, thank you so much, and thanks for moderating. We appreciate it. So I wrap up quickly here. I wanted to thank all of you for attending the NIH Behavioral and Social Sciences Research Festival this year. I want to particularly thank the Planning Committee for organizing such a wonderful festival with a lot of interesting talks. I think we'll all agree. I want to specifically thank Shannon Zink for giving her perspective on the extensive social and behavioral sciences that are supported by NINR. As I reflect back, there have certainly been times in the past when those in my role have felt like lone wolves howling at the moon, promoting the value of behavioral and social science research to the NIH mission. But there are now many NIH leadership positions like Dr. Zink who are strong supporters of behavioral and social science research and advance that mission on a day-to-day basis. I also want to thank the researchers who were nominated by their institutes and centers and who presented their interesting and impactful research at the festival this year. I think you'll all agree that was just an excellent set of presentations this year. I know that some of you may have attended only specific sessions of interest, but I hope at least some of you are able to attend most, if not all, of the sessions, because I think it provides a sense of the breadth, the scope, and the impact of behavioral and social science research that the NIH supports. Today alone, we heard about a range of research questions and topics, including HIV prevention, substance abuse, physical activity, sleep, and infectious disease mitigation, adherence, and vaccine hesitancy. And we heard about a range of populations studied, including many vulnerable and underserved populations, as well as a wide array of methods and approaches from self-report to GPS, direct observation, the use of vital statistics data, and modeling approaches in various observational and interventional designs. I must say it's been humbling and a bit overwhelming to be in the role of representing such a broad and diverse and impactful range of research for the NIH. I've only been able to do that justice because of the extensive support of the OBSSR staff, the behavioral and social science research program staff across the various institutes and centers, many of whom moderated the sessions over the last 2 days, and of course, the entire behavioral and social science research community that does such an excellent job of being good stewards of the taxpayers' dollars and producing important, impactful research that improves the nation's health. And I know that as Christine takes on this role in January, she can trust that all of you will continue to support her as she represents the behavioral and social sciences to the NIH leadership and to various stakeholders. So once again, I want to thank all of you for attending over the last 2 days. Thank again our presenters and the planning committee and all of you who worked on this. And I hope everyone has a good weekend. Thank you.